Ma'am, please start in 3, 2, 1. Please start, ma'am. We are live.
Namaskar and good evening, everyone. I welcome you all for today's webinar on Oncology Insights Forum 2, Clinical Updates in Lung Cancer and Breast Cancer. With great pleasure, I would like to invite Dr. R.K. Chaudhary, who is Director and Head Medical Oncology, Hemato-Oncology, BMT Metro Hospital and Cancer Institute, Delhi, and Metro Multi-Speciality Hospital, Noida, for the welcome and introductory note. Over to you, sir.
Thank you for kind introduction. Good evening and welcome to all the faculty and the audiences to this 2 days webinar meeting. So we'll be focusing on the lung cancer and the breast cancer, and the topics chosen for this meeting are very pertinent to the clinical practice. They are largely focusing on the targeted therapies and biomarkers. Without wasting the time, I would like to thank my academic partners, Roche, Lupin Oncology, Datar, Prajnas Kabi, Mark, and Samarth. And to begin the session, we have the very senior most oncopathologist, Dr. Darshana Patil here. Ma'am is there?
Yes, good evening, everybody. And thank you,
So
sir.
I would like to invite Dr. Darshana Patil. She does not require any introduction. She is a medical director of pathology and molecular technology at Datar Cancer Genetics Limited, Pune. And ma'am is going to give a talk on how to read and interpret next generation sequencing report.
Yes.
Over to you, Doctor. Please.
Yes, thank you. So I'll just start the screen share.
Please.
So I hope my screen is visible to everyone.
Yes, ma'am.
Okay, thank you. So as Dr. R.K. Chaudhary sir just mentioned that today we are focusing on the targeted therapies, especially in the lung cancer session. And that's why I thought what better way to start the session than discussing how to interpret the NGS reports. Because gone are the days when we were really discussing whether, such broad molecular profiling is necessary or sequential testing of EGFR and KRAS is sufficient. Nowadays, that is no more a debate. Doctors are facing or interpreting the molecular oncology reports in their OPDs regularly. And that's why I will just focus on what are the pre-analytical variables which may have impacted the information that you have at your disposal, or even the variant interpretation part I will be touching upon in a bit. So that the purpose of this session from my perspective is whenever you are interpreting a particular report, you should be aware about what exactly is included there, whether the information necessary is there, or if a particular variant is reported, whether it is actually relevant for the further clinical management of the patient or not. So as we know, the NGS sequencing can be done on the tissue samples or blood samples, and the pre-analytical variables, whether it is the tissue fixation, the tissue processing finally, which leads to formation of those FFP blocks, can also impact the data that you may receive in the report. Similarly, in liquid biopsy, also such pre-analytical variables such as the logistic time, the temperature, the type of tube the sample gets collected is going to be relevant. And this NGS sequencing, which is a very common terminology, but what exactly it entails, it is nothing but initial primary analysis of the sample, whether tissue or liquid, in the lab, where the relevant nucleic acid, usually the combination of the DNA and RNA, is extracted. And based on the requirement or the prescription that is being received to that particular lab, they will be utilizing a particular panel, whether it may be a small gene panel, it may be a broad panel, which also offers you the genomic signature information like MSI or TMB. So such panel will be utilized to generate a library of the sample from the sample. And this library then undergoes the sequencing on the NGS analyzer, and then the data gets interpreted with the bioinformatics pipeline. And once the variant interpretation happens in the bioinformatics, there is a reporting team which will be interpreting that particular variant in a clinical context, whether it's relation to the treatment selection, it's relation to the prognostication, and so on and so forth. So essentially, ISMO has already laid out a very good guideline about the interpretation of this NGS report and what exactly the medical oncologists need to know when a particular report is there in front of them. So this is a bare minimum layout or pertinent requisites laid out by the ISMO guidelines for a NGS report. Essentially, the details of the specimen type should be mentioned because it is very relevant. The variant allele frequency, the limit of detection, the way we are interpreting that variant may change whether it is detected in the tissue sample or the liquid sample. I will be utilizing some examples to elaborate on this further. Same way, when we are utilizing a FFP sample or tissue sample, the tumor cell content becomes very relevant, because if the tumor cell content is below certain cutoff, the sensitivity of detection of analytes such as copy number variations or fusion may be low if the tumor cell content was less than 25%, whereas the sensitivity of SNV may get impacted if the tumor cell content is less than 10%. So even though you may have a report in front of you which mentions no fusion detected or no amplification detected, but if the tumor cell content was not adequate, that is above 25%, that may have been the reason to have a false negative data for the fusion analysis. Similarly, variant allele frequency will play a role, whether, not only to determine whether it is a germline variant or somatic. I would also give you an example why the variant allele frequency section also should be paid attention to by the clinician, because that is in a way related to the quality of that particular variant or that particular data gets impacted by the limit of detection of the assay, and thus VAF will have relation to that particular area as well, which I will be elaborating. So these are the various factors which should be mentioned in a particular report that you are receiving. Many laboratories which are not really paying attention to the depth of analysis, which is necessary to give out a truly positive report out, that criteria may not be met by that particular laboratory, and hence in method sections it is pertinent for the clinicians to note whether the depth of the analysis has been mentioned or not. So tumor cell content, I will like to elaborate further in detail. Every assay that that the lab is utilizing has a limit of detection, as in if the variant is below that limit, then the lab may give out a false negative result. And this limit of detection has bearing because of the tumor cell content also. For example, in case of a tissue sample, if the tumor content is only 40%, and the particular clone in those 40% of the tumor cells, also the particular EGFR clone, for example, in lung cancer, is not present in every cell. If it is present only in 50% of the cell, then if the LOD of that assay is not up to 5%, then you may have a false negative result. That's why tumor cell content has to be reported in the report, and as well as what is the exact LOD of that particular assay, what depth was utilized for analysis of that report has to be noted down in that particular report. And that this depth of coverage or depth of analysis gets impacted even by the how many genes are getting processed. For example, many a times we see that we get fascinated by, oh, whole exome sequencing should be performed in a particular situation if the patient is affording to really understand more. But if the purpose of the sequencing is to analyze the targetable alteration, which can be exploited for further targeted therapy selection, then whole exome sequencing is not the ideal way. Utilizing either broad NGS or small NGS panel will give you more sensitive detection of the variants, because as the number of genes increase, the depth of analysis of that particular assay decreases. For example, if we are increasing the number of genes, the depth is not met. In whole exome, for example, the depth of analysis is usually between 100 to 200. Whereas in the targeted NGS panels, like 12 gene panel or 500 gene panels, usually the depth of analysis on tissue has to be 1000. And with such depth only, we will have a in a good sensitivity to detect a variant allele fraction of 5 to 10%, which is very much the bottom line for a tissue sample. Same way, when it is a liquid biopsy sample, this depth of analysis has to be minimum 10,000 to really not miss out on a particular clinically relevant information. In liquid biopsy, especially these acquired resistance mutations are not actually the predominant clone, and it is very much possible to miss out if the depth is not met properly. So in liquid biopsy, this depth, if it is not 10,000, such rare alterations like EGFR T790M, which develop post EGFR tyrosine kinase inhibitor therapy, may be reported false negative. So what are the guidelines laid out by these reference institutes? So as you can see here, CAP recommends that average coverage of 800 to 1,000 is required for analysis of a tissue sample. Whereas in case of liquid biopsy, to mention enough analytical sensitivity and specificity, the depth of the liquid biopsy panel has to be 10,000x. Just to illustrate the points that I already mentioned, why variant allele frequency is also to be paid attention to. So this is a particular report. This is a actual report where they had mentioned the diagnosis, which is also very important. What was the sample type and what was the tumor cell content? So these factors were ideally met. The requisites were ideally met, and they had reported KRAS and PIK3CA variant in a thyroid cancer patient. Now, of course, if this was a lung cancer patient, looking at the KRAS variant, the clinician may get discouraged in terms of the actionability of the report. There is no further tyrosine kinase inhibitors like EGFR that could be utilized. However, the more important relevant point here is the allele fraction. In tissue sample, a variant allele fraction of 0.05 or 0.1 was reported, which seriously challenges the correctness of this particular analysis or particular report. The variant allele fraction in a tissue-based analysis or tissue-based NGS report has to be at least above 5% for that variant to be considered as a true variant. So this particular tissue sample was again analyzed repeatedly at our lab and even at another lab, where you can see there is none of these earlier variants could be reproduced. So why this happens? There must be some issue in terms of yield of the DNA. Still the library preparation and those other factors were done, and false variants were reported. So essentially in a tissue sample, that's why this was the red alert for me to really question the correctness of this report. In a tissue sample, the reporting of such low variant allele fraction. So what is the importance of variant allele fraction? So if we see variant allele fraction more than 40% in a particular tissue sample, it all of course gives us some guidance that it might be a probable germline variant. So in the relevant genes like BRCA, ATM, we may want to confirm the germline nature by testing of the genomic DNA from blood. And another report I would like to discuss where that EGFR variant was reported at 90% frequency, and the tumor content was only 30%. So there was serious questioning by the oncologist why, about the correctness of the report. But there was simultaneous amplification in the EGFR gene. So there might be high variant allele frequency without the variant being probable germline nature if there is simultaneous amplification of the same gene. Also, there are multiple times questions being raised if there are two actionable variants. The clinicians do want to ask whether which is the driver pathway and whether I can deduct that information based on the VAF that is reported. Yes, to certain extent, but more than getting carried away by the variant allele fraction between those two reported variants, more important is the tier level or the evidence level for that particular gene in the context of the particular clinical malignancy. Another example of a variant allele fraction misleading the interpretation. So this is MSH6 gene variant where the variant allele frequency of 2% was reported by a lab. And based on this variant allele frequency, they went on to call this as a MMR deficient tumor, indicating pembrolizumab therapy, when actually in that particular report, there was no MSI high status detected. So now here should have been the red alert. This is a somatic MSS6 variant. If this would have been actual germline variant leading to MMR deficiency, the variant allele fraction would have been at least more than 40%. So these are the red alerts where the clinician must be very well aware of the context of the variant allele frequency and its interpretation. Because of the time constraint, I will just briefly run through the next two cases. So this is another case wherein what I discussed, that the clinician had questioned there is a EGFR mutation, there is a MET alteration, and which pathway should be considered for targeting. And of course, we know that MET may give resistance to EGFR tyrosine kinase inhibitors, so clinician was more inclined to utilize the MET inhibitor therapy. And when we went on and checked the variant allele frequency, the EGFR was 0.27% and MET was almost 50%. Just to highlight that it is a liquid biopsy report. However, the most important factor here is this particular variant is not actually a somatic variant. It is a germline variant, and there has been recent literature which has indicated that it is nothing but an uncommon germline single nucleotide polymorphism, as in it is a common polymorphism present in population, even though it is not very frequent. That's why the lab mistook it for probable somatic variant. However, the only targetable pathway in this particular patient was EGFR. MET was not a somatic alteration at all. So these are the situations which will warrant for the clinician's alertness. Just to discuss the last case now. Again, similar situation where EGFR variants were reported. There was compound heterozygous double mutations in EGFR, and there was also ALK fusion which was detected in this particular report. Because of this uncommon presentation. So as we know that EGFR and ALK are not all, commonly they are mutually exclusive. They do not concur commonly in the same sample. And that's why repeat testing was recommended at our laboratory. It was done, and also at Foundation, and the ALK was found to be a false positive reporting. So I just wanted to highlight the clinical practical issues that the clinicians may be facing, and what could be the highlights or red alerts for the clinician to either take a further testing or discuss these particular reports with the relevant laboratory person so that the patient management doesn't suffer. So just a summary of the sessions, today's session. Tumor content is very important factor. The lab has to report if it is a tissue sample, what was the tumor content that is, of the sample that they utilize. In case you see that tumor content is less than 25% in that particular tissue sample, the sensitivity of the amplifications as well as fusions may be affected, and that may be a false negative report. More important than the number of genes, clinicians should be more vigilant about the depth of the analysis that particular lab is utilizing. There are multiple labs which are not utilizing adequate depth. So there are certain labs which may utilize 250 to 300 depth for tissue as well as liquid, whereas we should be aware that for tissue, the minimum depth of coverage is 800 to 1000, that should be met. And for liquid biopsy, the depth of coverage should be 10,000. In the methodology section, it is the duty of the laboratory and also the clinician have to counter check whether the analytical performance of that panel along with the limit of detection has been mentioned by that lab or not. So this depth, many a times it just claimed in the brochures, and if you get the patient's report, they will not mention this because they do not meet it in the actual analysis. So these are such sections on what was the minimum depth, what was the data of sensitivity and specificity of the particular panel utilized has to be mentioned in the particular report. The final takeaway that, of course, variant allele frequency you should be paying attention to, so it can guide you to differentiate germline versus somatic. Whether that particular variant is below LOD, it will reduce the actionability of that variant, and you should interpret with caution. And subclonal variant, which are also a category wherein that particular variant is not present at much significantly less frequency, that may not be the actual driver of the disease. Coexisting mutation data in rare situation, there may be coexisting mutation, but you have better to counter check existence of such mutation by discussion with the labs or by repeat testing. So these, and that's why it is very important that the tumor board interactions, which include the molecular pathologists, the molecular biologists, the clinicians, are necessary, especially in context of interpreting a NGS report. With that, I will stop the screen share and I will be happy to take any questions, if any.
Thank you, Dr. Darshana Patil, for such a lucid, elaborative, and yet simplistic talk of such a complex topic. And this is really going to help us in a clinical practice. And also, thank you for sharing the depth of analysis is very important, and how to check the lab credibility of the lab, whether this lab is equipped with such a instruments for testing or not. Thank you, ma'am. And we'll keep the question and answer at the end of the all the sessions. Thank you. So next, I would like to invite the next speaker, and next speaker is Dr. Sunit Lokwani from the Indore. Dr. Sunit Lokwani is the consultant medical oncologist from the Indore. He is working with Kokilaben Dhirubhai Ambani Hospital, and Dr. Sunit is going to talk on the time to raise the bar in ALK-positive non-small cell lung cancer. Dr. Sunit, please.
Thank you, sir. Thanks a lot for the opportunity. Am I audible, sir?
Yeah, you are audible.
So I'll go ahead. I can share the screen, right?
Right.
Yeah. So thanks a lot for giving me the opportunity to talk on ALK-positive NSCLC. I'll be briefly talking about a few things. In the subsequent slides to come, we'll be focusing on what is the first line, given the host, the basket of ALK-positive drugs we have. And ALK-positive seems to be more of a rejected or not looked upon kind of mutation per se. But nowadays, in the last 7 years, when the whole landscape of NSCLC management has changed drastically, pointing more to molecular alterations only, ALK has really emerged as a very promising marker and a promising driver mutation which can be acted upon, and we have many things in our basket to act upon it. So the idea of raising the bar is coming out of the cringes of the earlier two drugs which we used to have and coming to a newer drug. And most of my talk will be focused on first line management, the subsequent progression, and secondly, what second line we can give, and why we should place the NGS, complete genomic testing, when you have a first line resistance with ALK-positive and NSCLC cases. So that's why the topic going to be like that, time to raise the bar of things. So I'll proceed with this. Just a brief 2 slides about the ALK positivity part, the epidemiology, why I need to focus upon. It's nearly 5% of patients with advanced NSCLC, most of the non-squamous histologies. Patients usually present with ALK positive are roughly between 3% to 13% of the total strata, which is designated as driver mutation positive. The incidence of ALK positive is higher mostly in patients with non-squamous, the ones who are never smokers, the ones who are on the younger bracket of disease, on the younger age part, most likely females, and patients who do not have other single actionable driver mutations, that is the EGFR or KRAS. The good part and the bad part at the same time is clinical characteristics most of the time do not match ALK positivity. It's somewhat of a surprising, nowadays not much surprising, but somewhat of a surprising kind of a revelation which is revealed after the molecular work. So as I mentioned earlier, around 3 to 13% of the population which is affected by NSCLC usually turns out to be ALK positive. It's nearly reported in 7% of the lung cancer. The incidence has been variable in different regions of India. Most of the east side of India has got more ALK positivity. That's what I could remember from epidemiology. So this is the basket of drugs we have: Crizo, Seri, Elec, Brica, and lorlatinib. These are the first and approved treatments for patients with advanced ALK positive. And the different trials mentioned here definitely put forward why we need to use them. What I need to focus upon is alectinib so far has the largest body of evidence with 4 trials backing it up: J-ALEX, ALEX, ELISA trials. So, with consistent results in phase 3 trials, primarily supporting alectinib as the first-line treatment options for patients who are treatment naive, advanced ALK positive, and SCLC. So, it's a 5-year update from the ELISA trial, wherein alectinib was head-on compared with crizotinib, the first-line one ALK positive drug, in treatment-naive Asian population. So, the origin of alectinib primarily comes from more of a Japanese origin. So, definitely the population compared here is more towards the Asian agenda. So if we have a stage 3B of ALK positive case, definitely the study was done in Asian population. Patient usually had a very good ECOG. Centralized Ventana ALK testing was done. So a distribution of 2:1 was carried out in 200 patients, wherein majority received the alectinib part. The lesser part received the crizotinib. A no crossover permission was there, so that clear understanding of whether alectinib is really superior in terms of PFS or not can be carried out. So treatment was done until disease progression, toxicity, or withdrawal. Primary endpoint was PFS by investigator. Secondary endpoint definitely was time to CNS progression, the overall response rate by investigators, duration of response, and definitely overall survival. So median duration of survival follow-up was done 61 months in alectinib versus 51 months in crizo. So these are the baseline characteristics. Definitely here in the study, a preponderance of the main population was seen. The median range of age was 51 years in alectinib arm, crizotinib arm. Again, the 50 years population was more or less the same. The ECOG PS was good in most of the patients. And again, CNS metastasis was seen in most of the patients receiving alectinib and crizotinib arm as well. Baseline characteristics were balanced. That's what I wanted to mention. Nearly 35% of patients in alectinib arm had CNS mets. So if you can appreciate, the delta is quite huge. So in an updated analysis, a durable PFS benefit was obtained with alectinib, 41.6 months compared to 11.1 months. So this data is nearly consistent with the global ALEC study, which showed 34 months versus 10.9 months. So this again, PFS benefit in case of CNS mets. Systemic and CNS efficacy of alectinib in Asian patients was very much evident. Again, 42 months versus 10 months, and without CNS mets at baseline, 41 months versus 12 months. So these findings are definitely consistent with the global ALEC study. Again, a good delta was seen, a good median PFS attained with alectinib compared to crizo. I'd like to mention again, OS in the intent to treat population when it was observed. At 5 years, OS data remains still immature. A clinically meaningful improvement in 5-year survival was seen with alectinib, 66% versus 56% for crizo only. And this is what I wanted to mention. In context or in comparison with the ALEC study, it fared similarly, where in ALEC study, alectinib showed 62% versus 45% for crizo. Again, OS to the patients who had a CNS disease at baseline, alectinib definitely was superior. So time to CNS progression in the intent to treat population. So patient with, treatment of Asian patients with alectinib delayed the time of CNS progression, resulting in an 84% reduction in the risk of CNS progression with alectinib compared to crizo. Again, consistent with the ALEC study per se. So post-progression therapy, patients who progressed on crizo, 30% of them were basically receiving ALEC following disease progression. That's what I wanted to show in this one. So overall safety profile, if you consider the grade 3 serious effects were there with alectinib, but the median duration was 3 times more longer for alectinib compared to crizo. It had a more favorable safety profile compared to crizo, which showed odd symptoms, odd behaviors, neutropenias, nauseas, ECG QT prolongations, which were not evident in alectinib. So this is one thing where alectinib fared well as well. So the compliance definitely increases when the right side effect profile is better. So to conclude or to summarize, a 5-year update from a phase 3 ALICIA study, that alectinib first line 600 mg BD dose continues to demonstrate clinical benefit for Asian patients with advanced ALK positive and SCLC. A median PFS was far superior compared to crizo, that is 41.6 months. Irrespective of CNS mets at baseline, it delayed the time to CNS progression, and definitely clinically meaningful increase in the 5-year survival rate was evident. And definitely with a 3 times longer treatment duration compared to crizo, good safety profile, and literally it's somewhat of a bang-on drug which is to be recommended for a first line. So our clinical thing primarily, what after alectinib? So there's a study wherein lorlatinib was used. It was approved for the second line patients who progress in first line Alex, Seri, or Crizo, plus more than one other ALK TKI. So lorla was the savior drug here. The inclusion criteria was metastatic non-small cell, ALK positive, ROS positive disease confirmed by IHC. Patients more than 2 lines of therapy also were included in this one. The primary endpoints, percentage of patients overall intracranial objective responses was the primary endpoint. Secondary endpoints definitely remain OS, DOR, and other things. Definitely efficacy, definitely safety was one of the things. So they had divided it very well. The division in the study was quite excellent. The experimental arms were quite divided very well in this case. What we need to see here is there were 3 arms which mentioned that prior non-crizotinib ALK TKI taken plus chemotherapy, 2 prior ALK TKIs plus chemo, 3 prior ALK TKIs plus chemo. So there was a definite delineation while comparing. So what they want to mention here is lorlatinib has demonstrated clinical activity in patients who have progressed on first-line alectinib, on patients who have had crizo plus CT, on patients who have received 2 ALK positive drugs plus chemotherapy as well. So what they mention here is median PFS benefit was 5.5 months. Safety profile, as long as you go, the major issue here were lipid alterations with lorla. Quite significant edemas and peripheral neuropathies were seen. So the idea here is alectinib in first line helps in optimal sequencing for your patients. There are different resistance mechanisms with alectinib. There are bypass mechanisms, ALK-dependent progressions, and then there is a transformation to HCLC as well. So what is the role of complete genomic profiling on decision-making process in ALK rearranged non-small cell? The idea is it has got a significant impact. You can definitely find out which thing has caused the mutation, which minor detail has caused the mutation, and subsequently there is a method with which you can definitely line up your second line treatment. If you have an ALK mutation, ALK fusion plus, you can definitely go ahead to platinum-based chemotherapy with brigatinib after brigatinib. If pemetrexed was given earlier, then lorla can be taken up. So that's why a genomic profile is needed to sequence your second line TKI oblique second line treatment after progression. So again, the same thing which I like to mention here. If a TKI like alectinib is used in the first line and which is followed by an NBS on progression, the choice of later line of treatment would depend on the right resistance, and only those patients who are sensitive to lorla will get lorla. If they're not sensitive to lorla, they can receive some other line treatment. This will ensure an optimal sequencing and better response rates with the lorla on the second line part. So if you can see here, the resistance mechanisms wherein sensitivity in maximum fraction goes on increasing to lorla seems more like a culture sensitivity chart to me. And if you can understand this part, that there are many point mutations which happen when you have complete genomic profiling, which can definitely alter your treatment profile and help a decision making while shifting to second line treatment after LA. As far as guidelines, I'd like to take help of 2 of the most commonly used guidelines, NCCN and ESMO. NCCN says alectinib is the preferred drug when there is ALK rearrangement discovered prior to first line systemic therapy or naive patients with ALK mutation positive NSCLC. And subsequently, definitely a complete genomic profile helps in second line placement of drugs. Again, when it comes to ESMO guidelines, the algorithm clearly mentions there is a class 1 grade A recommendation for alectinib here as well, based on guidelines, based on trials. The maximum data is there for alectinib. That's why we are going to push it here more. So it is a preferred option for standard of care and standard of care for patients with ALK positive NSCLC. The reason is it has just demonstrated a very good median PFS, be it Alex trial or Alicia. It's effective against CNS Mets as well. It's the only ALK TKI to have demonstrated clinically meaningful benefit in OS versus crizotinib. Well tolerated, side effects are lesser, manageable safety profile, and long-term use can be carried out. Thanks a lot. You've been a great audience. Thank you very much for this.
Thank you, Dr. Sunit, for such a knowledgeable talk.
Thank you, sir.
Really, it was wonderful to listen to you. It was very calm and extensive talk.
Thank you.
Thank you. We'll take up the questions at the end of the complete session.
Sure,
And
sir.
for the next session, I would like to invite Dr. Nagendra Sharma from Max Hospital. Dr. Nagendra, So Dr. Nagendra is the principal consultant at Max Super Specialty Hospital, Saket. And Dr. Nagendra is going to talk on the optimizing use of neoadjuvant immunotherapy in non-small cell lung cancer. Dr. Nagendra, please, over to you.
Thank you. Thank you very much, Dr. Arke Chaudhary, for giving me the opportunity to be part of this well-organized, very informative, and thought-provoking scientific session. And I'll come straight to the point. The topic allotted to me is optimizing the use of neoadjuvant immunotherapy in NSCLC. So we all know that getting an advanced cancer diagnosis and going through its treatment, it's not only devastating for the patients, it's actually devastating for the entire family. The challenges which this patient faces, they are not only physical, they are emotional, they are psychological, they are spiritual, and above all, they are financial. Over the last couple of years, we have seen there is a paradigm shift as far as our understanding about NSCLC, and the fight is at molecular level these days. We are having a lot of trials in the advanced setting, and now these drugs, the immuno-oncology drugs, are being tried in neoadjuvant setting when the intent of treatment is curative. As we all know that in advanced setting, no matter whatever newer drugs or molecular agents we use, however the costly of the treatment is, the intent of treatment in advanced setting is still palliative. The patient have to live with the disease and patient have to live with the treatment. But now we are using these immuno-oncology drugs in neoadjuvant setting in which we can give a patient cancer-free life after a curative treatment. So as we all know that the intent of giving neoadjuvant treatment is to downstage the disease or downsize the disease so that it will come into the preview of surgery. Once the surgical session is done, to take care of the baby tumor cells, we have to give adjuvant treatment. And this is the rationale which is used in using the biological agents or immune checkpoint inhibitor treatment in resectable NSCLC, right? So immunotherapy is being tried in resectable, potentially resectable NSCLC. And in post-operative setting also, we are having immuno-oncology drugs, but we have to remember a few things. So I'll come to the trial first. So first trial, which have changed the management of neoadjuvant treatment, is Checkmate 816 trial. So we know that in neoadjuvant setting in potentially resectable NSCLC who are newly diagnosed from stage 1B to stage 3A NSCLC, the size of the tumor should be greater than 4 centimeter in this trial. Good performance status. And one thing we all have to remember that the patients who are having EGFR mutation or ALK aberrations or ALK alterations were excluded from this trial, right? So this trial was randomized trial, phase 3, international trial, in which number of patients enrolled is 358. It is 1:1 randomization in which nivolumab at the dose of 360 milligram Q3 weekly plus chemotherapy Q3 weekly, 3 cycles are given. It was compared head-on with chemotherapy Q3 weekly upfront. Then, after 3 cycles of chemoimmunotherapy agents, patient was reassessed for any progression or any response, and surgery was contemplated. And within 6 weeks of post-treatment, optimal adjuvant chemo plus minus radiation is given, and the patient is kept on follow-up. The things which we have to remember in this trial is that 37% of the patients in this trial were stage 1B or stage 2. 63% of the patients were stage 3A. 50% of PD-L1 greater than or equal to 1% were taken into consideration, and none of the patients were having EGFR or ALK aberrations, right? So this is a very, very important point which is coming out from this trial, and only 3 cycles of neoadjuvant immunotherapy is used along with chemotherapy, and those patients who have shown response, they underwent surgery. So what came out from this trial? Checkmate 816 trial, the EFS with the neoadjuvant nivolumab plus chemotherapy versus chemotherapy, 3 years of data is published now. So in which they have found out that median EFS in months is not reached. And the hazard ratio, look at the hazard ratio. Hazard ratio is 0.68. And in the chemo arm, the competitor arm, the median EFS in months is 21.1 months. So as we all know, the lesser the hazard ratio, better is the experimental arm, so favoring nivolumab. And look at the Kaplan-Meier curves. They started separating early and they stay separated as the time passes. At 1 year, the patients who are the event-free survival was 77% for the experimental arm, that is nivolumab and chemotherapy, as compared to 64 in the competitor arm. It was 65% at 2 years, and it is 47% EFS was there in the competitor arm at 2 years. What about at 3 years? 3 years is 57% for event-free survival is there, and 43% of patients were event-free in the competitor chemotherapy arm. So the key highlight which you have to remember is the pathological CR is 24%, and mean pathological response was 37%. The Checkmate 816, the overall survival with neoadjuvant nivolumab plus chemotherapy versus chemotherapy alone, 3-year update have shown the median overall survival have not yet reached. What about hazard ratio? Hazard ratio is again 0.62, favoring the experimental arm. So as you can see that 3-year update, 78% of the patients were alive as compared to 64% of patients in the comparator arm, that is chemotherapy alone arm. So obviously this trial is a positive trial, and patient have to receive only 3 cycles of nivolumab upfront, and you know the doses is 360 milligram Q3 weekly flat. And these patients are better operable, and the surgeons are even happier with this trial, and they are able to reset the patient with the EFS advantage. So if we look at the first plot, as you can see, the stage 1B and stage 2, the dots are on the right side of line of unity, favoring the experimental arm. Even stage 3 also, it is even better. Those patients who are having a lesser PD-L1, what happens to those? We know that those patients who are having a higher PD-L1, they will respond better to this combination. The answer is yes. So those patients who are having a higher PD-L1, that is greater than or equal to 50%, they are having a better response. But even those patients who are having a lesser PD-L1, they are having an excellent response. Look at the hazard ratio, it is still positive. So that is what we have to remember. Majority of patients in this trial were ECOG performance 0 or 1. And as far as Asian patients are concerned, Asian patients, North American and European patients were the major patients. The major patients were from Asia. And the female patients were 103 and male patients were 255. So what happened to EFS with neoadjuvant neo plus EP versus chemotherapy? So neo EP, the EFS is 54.8 and hazard ratio 0.77. So obviously neo EP also is a option which can be explored with an excellent EFS advantage. Although the Kaplan-Meier curves started separating after nearly 8 to 9 months. Hazard ratio 0.77. The pathological CR, if we see by and large, so this drug have shown that those patients who are on neo plus chemotherapy, they are having a better responses as well as pathological CR is concerned. It is 24 versus just 2.2. As you can see, the odds ratio is 13.94, favoring the nivo plus chemotherapy arm, irrespective of PD-L1, irrespective of smoking status, irrespective of histology. These patients have done well. OS data, already we have shown that it has not yet reached, and 78% of patients are still alive at 3 years, which is a major landmark of this trial. Checkmate 816, the pathological response and survival, if we see, so nearly, as you can see clearly, this chemotherapy plus nivolumab arm is faring better. Pathological CRs, the event-free survival is not yet reached, and this is favoring nivolumab plus chemotherapy arm. Those patients who are having a pathological response and survival by EFS by primary tumor, major pathological response, which was published in ASCO 2020-22, also have shown that at nearly 2 years, 86% of the patients are EFS, like event-free and survival benefit is there. And with chemotherapy alone, they are not faring that better. So most important thing which we have to remember is, in this trial, in the post-hoc analysis of Checkmate 816, pathological CR, major pathological response in the primary tumor associated with the improved EFS with neoadjuvant nivolumab plus chemotherapy versus chemotherapy alone in resectable NSCLC. In the nivolumab plus chemotherapy arm, EFS improvement in the patients who had pathological CR was observed regardless of baseline, stage, or PD-L1 expression. The depth of pathological regression with neoadjuvant nivolumab plus chemotherapy may be predictive of EFS outcome at 2 years. Neoadjuvant nivolumab plus chemotherapy showed a similar safety profile in patients with or without pathological CR or major pathological response, and was consistent with old treated patients. So investigators concluded that these results support pathological response as an early indicator of EFS benefit with neoadjuvant nivolumab plus chemotherapy arm. There's one more trial, that is Keynote 671 trial. So we know that the PD-L1 and PD-L1 inhibitors are the standard of care for patients with advanced or metastatic NSCLC who have not demonstrated, who have demonstrated the benefit when administered before or after resection in early stage NSCLC. So recently reported phase 3 AGM and NeoTorch trials showed a significant EFS benefit with perioperative approach that includes neoadjuvant and adjuvant PD-1 or PD-L1 inhibition. The Keynote 671 was designed to evaluate the perioperative pembrolizumab plus chemotherapy in patients with early stage NSCLC patients. The most important thing which you have to remember in the trial schema, as debated in this slide, that this is a randomized double-blind phase 3 open-label trial, which is 1:1 randomization is there. The most important thing we have to remember is 30% of the patients were in stage 2, 1/3 of each PD-1 group, that is less than 1%, 1 to 49 and 50% were there, and 5% of these patients were carrying EGFR or ALK also, right? So the pathological confirmed resectable stage 2 or stage 3 or stage 3B, those patients who are having N2 disease, NSCLC based on 8th AJCC, were taken, who have not received any prior therapy, were able to undergo surgery, and provision of tumor sample for PD-1 evaluation was there, and who are in excellent performance status. The total number of patients enrolled in this trial was 786, and it is 1:1 randomization, in which pembrolizumab at the dose of 200 mg IVQ 3 weekly was added to gem platinum or pemetrexed platinum for 4 cycles. It was compared head-on with placebo plus chemotherapy doublet with platinum for 4 cycles, and patient underwent surgery. And those patients who underwent surgery, they were given pembrolizumab in perioperative setting also for 13 cycles. So by and large, 1 year pembrolizumab given for these patients. The strategic factors for this was stage 2 or stage 3. PD-L1 TPS score of less than 50 and greater than 50 were stratified. Histology, squamous and non-squamous, and geographical, whether they're from East Asia or not from East Asia. The dual co-primary endpoint of this trial was event-free survival as per investigator's review or overall survival. The key secondary endpoints were major pathological response, pathological CR rates as per blinded independent pathological review, and safety. So remember this point, the 30% of patients were stage 2 and 1/3 of PD-L1 like less than 1, 1 to 49 or 50% were taken into consideration. So this was a trial schema which already I highlighted, and these patients were given in neoadjuvant these cycles, and adjuvant also they were completed for 13 cycles. So by and large, these characteristics of both the competitor arms were equally balanced, and majority of patients of this trial was non-squamous histology and were in excellent performance status. Majority of patients were from not from East Asia, they were from other than East Asia, and nearly 62% of patients will former smoker, and 24% will be were currently smoker, and never smoker was 13.6%. So 1/3 of patients were in greater than 50%, 1/3 of patients in 1 to 49, and 1/3 of patients with less than 1% PD-L1 TPS scores. So majority of patients were in stage 2 and stage 3A. Only 15.6% of patients were in stage 3B. 3.5% of patients, I already mentioned, were having EGFR mutations, and only 3% of patients will be having ALK translocation. So majority of patients underwent complete resection. That is nearly, you can see 92% of the patients. Incomplete or R1 or microscopic mets resections were positive, that was 5.2, and R2 resection was just 1.2%. So majority of patients underwent lobectomy, followed by pneumonectomy, 11.4%. Lobectomy was 78.8%. Bilobectomy was 8%, and exploratory thoracotomy 1.2%. The 30-day all-cause mortality was just 1.8% with pembrolizumab arm. This is what we have to remember in this trial. So what were the primary endpoints, whether we were able to achieve or not? So answer is pembrolizumab, the median EFS not reached. And if you can see the placebo arm, it is 17, right? As you can see in the Kaplan-Meier curve, it is the hazard ratio is 0.58, favoring the pembrolizumab arm. So patients are able to achieve the EFS advantage. This is the first plot. As you can see, all the dots are on right side of line of unity, favoring the pembrolizumab arm, which is faring better, irrespective of the geographical location, irrespective of the smoking status, irrespective of histology and stage. All stage 2, stage 3A, stage 3B, even if those patients are in nodal positivity, they have fared better. Those patients who are having EGFR mutation also, you can see they are faring better in this trial. Keynote 671, the primary endpoint, overall survival, as you can see, not reached, and placebo it is 45.5 months. And look at the 2-year, the percentage of the overall survival, it is 80 versus 77% by and large. Hazard ratio is 0.73, favoring the experimental arm, that is pembrolizumab plus chemotherapy arm. So pathological response by the blind independent pathological review also is favoring. The delta advantage is 19.2% as well as major pathological response, and pathological CR rate is the delta advantage is 14.2%, as you can see clearly in this bar graph. The Keynote 671 exploratory analysis of EFS by pathological response also favors the experimental arm. These patients are able to achieve the pathological CRs better as compared to the competitor arm. So majority of patients were having a better response. Only the grade 3 to grade 5 adverse treatment-related adverse events were seen. That is autoimmune side effects which can happen, which is well managed by the tapering dose of steroid. Keynote 671, Aniga's treatment-related adverse event occurring in greater than 10% of the patients across treatment phase. As you can see clearly, majority of patients were having grade 1 or grade 2. Hardly any patients were having grade 3, grade 4 side effects. Most common side effects were nausea, leukopenia, anemia, fatigue, constipation, appetite loss. So by and large, the investigators' conclusion were in the patient with resectable stage 2 and stage 3B, neoadjuvant pembrolizumab plus chemotherapy followed by surgery and adjuvant pembrolizumab was associated with a significant improvement in EFS vis-a-vis neoadjuvant chemotherapy and surgery alone. The median EFS not reached in the pembrolizumab arm. It was just 17 months in the placebo arm. Hazard ratio 0.58. The OS difference was not certainly different in any of these analyses and will continue to be tested. The perioperative pembrolizumab was associated with a significant improvement in the pathological response. Exploratory analysis suggested benefit with pembrolizumab regardless of whether patients attained pathological CRs or major pathological response. The safety profile were as expected based on the individual agents. The investigator concluded that these findings support a perioperative pembrolizumab as a promising new treatment option for patients with resectable stage 2, stage 3A, stage 3B with N2 positivity and a CLC. This is one more trial, NeoTorch, in which neoadjuvant treatment with anti-PD-1 or anti-PD-L1 antibodies for patients with resectable NSCLC have been demonstrated in multiple phase 3 trials, like for nivolumab, Checkmate 816, which already we discussed, atezolizumab, Empower 010, pembrolizumab, Keynote 091, durvalumab, AGN study. The phase 3 NeoTorch trial compares toripalimab plus chemotherapy versus placebo plus chemotherapy in patients with untreated resectable stage 2 or stage 3 NSCLC. The current pre-specified interim analysis of EFS in patients with stage 3 NSCLC was previously presented in as a part of April ASCO monthly plenary meetings. So NeoTorch study, so it was a randomized, double-blind, placebo-controlled, multi-center phase 3 trial. The neoadjuvant toripalimab 240 mg IV plus platinum-based chemotherapy for 3 cycles were given Q3 weekly. It was compared with platinum doublet with placebo. The patients with newly diagnosed resectable stage 2, stage 3 NSCLC without EGFR and ALK mutations were taken into consideration, and majority of patients were in excellent performance status 0 or 1, and number of patients were 500 odd. So patient underwent surgery, then followed by adjuvant toripalimab plus platinum was continued, and then maintenance toripalimab was given for 13 cycles. Although toripalimab is not yet available in India, the primary endpoint of this trial was EFS by investigator. The secondary endpoint was overall survival. The pathological CRs by blinded independent pathological review, both stage 3, stage 2 were taken into consideration. The measured pathological response rate by BIBR also was taken into consideration in primary endpoint, and key secondary endpoint was, as I already told, overall survival, pathological CR, and EFS. DFS and safety also were taken into consideration. The NeoTorch, the baseline characteristics were equally balanced in both the arms, and majority of patients were in excellent performance status. Squamous histology was 77% in toripalimab, non-squamous was 22.3%. Majority of patients were having a PD-L1 of greater than equal to 1% TC score. Majority of patients were stage 3A, hardly 1 in 3 were stage 3B, right? So this trial also have shown that these patients are able to perform better. The EFS is not yet available. The 12 months EFS is 84.4% as compared to 57% in placebo plus chemo. 2 years EFS was 64.7% with toripalimab plus chemo as compared to 38.7% with placebo and chemotherapy. Major pathological response by blinded independent pathological reviews 48.5%, which is good, and DFS the difference is by 40.2%. NeoTorch EFS also already has shown that it is not yet reached. So this is a trial which we are looking forward. Once the drug is available, we will be having a hands-on experience of this drug also. So NeoTorch, the most important thing which you have to remember, the interim analysis of phase 3 NeoTorch trial for the patient with stage 3 NSCLC found that addition of toripalimab plus chemotherapy resulted in significant improvement in the EFS, although it is not yet reached, and higher major pathological response and pathological CR rates. EFS improvement consistent across the key groups Those patients who are having a PD-L1 less than 1% also having hazard ratio 0.59, favoring the experimental arm, and squamous histology were faring better as compared to non-squamous histology based on the hazard ratio. Investigator concluded that the results of NeoTORCH and other trials established the standard of care for stage 3 NSCLC as a perioperative immunotherapy plus chemotherapy. Aging trial also just a brief touch. This is a perioperative regimen in which durvalumab plus platinum doublet for 4 cycles was compared head-on with platinum doublet with placebo, in which this is a 1:1 randomization, and stage 3B, stage 2A, all the patients and 8th AGCC were taken into consideration who are resectable. Lobectomy, sleeve resection, bilobectomy, and another as a planned surgery, and confirmed PD-L1 was evaluated, and there was no EGFR and ALK which was taken into consideration. The primary endpoint of this trial also was pathological CR and EFS, and key secondary endpoints were major pathological response, DFS, and overall survival. Post-surgery, durvalumab was continued for 12 cycles at the dose of 1,500 mg IV Q4 weekly. So initially, durvalumab was given in the neoadjuvant setting as a 3-weekly regimen of 1,500 mg, and in the maintenance it is given 4 weekly. So what came out from this trial was the EFS is not yet reached and hazard ratio 0.68. And look at the probability of EFS advantage. It is 73.4% at 1 year and 63.3% at 2 years, which is much better as the competitor arm. The median follow-up was 11.7 months and EFS maturity percentage was 31.9%. As you can see in the first plot, all the dots are on the right side of line of unity. No matter whatever the histology is, no matter whatever the stage of this cancer, whether it's stage 3 or stage 2, all the patients have got a better response. Even those patients who are having less than PD-L1 1% also have fared better. So pathological CRs, the correlation with pathological CRs, as you can see, the difference as far as pathological CR is 13%. That's a data advantage. The role of adjuvant treatment was also questionable, and this is what came out from this trial. So adjuvant Empower 010 also, we know that atezolizumab was trialed as an adjuvant setting. 12% were stage 1, 50% were stage 2, 40% were stage 3, 55% were PD-L1 positive, 15% were patients who are having a driver mutation, which was picked up in this, and the majority of patients were having the checked for the exploratory endpoints, that's overall survival, and those patients who are having stage 1B and tumor size of greater than 4 centimeters were taken into consideration. Either lobectomy, PD-L1 was checked, and ECOG performance status was taken into consideration. So these patients were initially given cisplatin pemetrexed or cisplatin plus gemcitabine docetaxel vulnerable for 4 cycles, then 1:1 randomization with atezolizumab in adjuvant setting, and they were continued for 16 cycles or 1 year. 1,200 mg Q3 weekly was a dose which was used. So this trial have also shown that this is a wonderful option. Median DFS are not yet evaluable, and the median DFS is 42.3% as compared to best supportive care. And atezolizumab have shown that irrespective whether your stage is stage 2 to stage 3A or in the TPS, the PD-L1 TC score is greater than equal to 1% in all randomized patient and international treated population, it is faring better. So US FDA approval it got on 15th of October 2021. Since then, we are all using this. So by and large, this is the summary of these trials. So we are having multiple options in neoadjuvant treatment. We are having Keynote 671, Empower 030, Checkmate 770, AGN. We already having Checkmate 816. Already we discussed. The primary endpoints of this trial and the stage which were taken, the classification of 7th AGC was used in Checkmate 816, and subsequent trials 8th AGC also was used. So by and large, the net result of these trials, which you have to remember, this is the most important slide of this presentation, that in neoadjuvant immuno-oncology drugs, Checkmate 816 is having an EFS advantage. The benefit is that only 3 cycles of neoadjuvant nivolumab is given along with chemotherapy. There was nothing as far as immunotherapy is concerned in adjuvant setting was used in this trial. It's a positive trial. EFS and pathological CRs are much, much better. Perioperative, we are having 5 trials. Major pathological response and pathological CRs benefit was seen in Keynote 671, AGN, NeoTORCH, Checkmate 770, and Rational 315. EFS benefit is seen in Keynote 671, AGN, NeoTORCH, and Checkmate 770. OS benefit is seen only in Keynote 671. The addition of adjuvant component appears helpful but not proven. Adjuvant IO trials, there are 2 DFS positive trials are there. Empower 010 and Keynote 091. The consideration is that upfront surgery for stage 1 and stage 2. Circulating tumor DNA also has questions. Mark, which we have to explore. Adjuvant targeted 2 positive trials are there. Adura, we already know. Helena, molecular testing is the key for optimal outcomes, right? The current standard of care for early stage NSCLC, remember that accurate stage, discuss in multidisciplinary tumor board, at least get input from the surgeons who are thoracic surgeons, whether it is potentially resectable or not. radiation oncologist, medical oncologist, pathologist, and imaging specialist, nuclear physicians. Test for EGFR, ALK, and PD-1 always. Adjuvant target treatment, standard of care for EGFR positive and ALK positive. Already EDURA and ELINA trials are there. New adjuvant perioperative IO, standard of care for all operable stage 3 without driver mutations. Many options exist. And duration of therapy, major pathological response, pathological CR response, PD-L1 levels, circulating DNA, etc. may help us to determine the best choices. Stage 1 and stage 2 more controversial now, and surgery alone on adjuvant approaches can still be considered for many, and for neoadjuvant and perioperative also appropriate for some. The caution should be in stage 1B with very limited data as of now. The exciting times for early stage NSCLC is there right now. I think we are going in a golden era of early stage NSCLC right now, and we still have to work to do with biomarkers and comparative trials. So this is what I want to convey, that the intent of treatment in these patients is curative. So by and large, I will summarize that ultimate aim is that we have to cure these patients, and the more we know, the more we realize how much we don't know. I think message is loud and clear. Thank you. Thank you very much for the opportunity to be a part of this well-organized scientific feast. Over to organizers, please.
Thank you, Dr. Nagendra Sharma. As always, you have been a rock star. Your talk was wonderful. And when we started our practice 10 years ago, there was no immunotherapy was available, right? And in the last decade, it has emerged from the metastatic setting, from second line, third line to the first line metastatic, then in adjuvant setting, and now in neoadjuvant setting. So it has been like, from oncology point of view, this last decade has been wonderful. And today's era, we can't think of treating a cancer patient without including the immunotherapy. And maybe in the next 5 years, it will be all immunotherapy all over. So thank you, Nagendra, once again. Thank you.
Thank you. Thank you very much, sir, for the opportunity.
Right. So next talk, we are going to discuss about again immunotherapy in the non-small cell lung cancer. We'll be focusing on the atezolizumab as the first line in stage 4 non-small cell lung cancer. Can anybody help us? Me sharing the slide?
Ishant, can you please share the slides?
Pardon? Are slide visible?
No, sir.
I believe somebody else is sharing the slide, so I'm not able to share the slide.
So now you can see.
Is it visible now?
Yes, sir, it is visible. Just make it full screen. Yes, sir.
So very good evening to everyone. So I'm going to discuss about the redefining the management of the non-small cell cancer and with atezolizumab now and the next. So basically, I'll be focusing on the role of atezolizumab in the first line setting in non-small cell lung cancer, wild type. So when we talk about the first line treatment option in metastatic non-small cell lung cancer, we do have a lot of options in the patient who don't have any actionable driver mutation. Of course, if the driver mutation are there, then we'll be treating with the oral TKI. So what various options available are chemotherapy along with the anti-angiogenic drug, or immunotherapy as a monotherapy, or immunotherapy combined with the chemotherapy, or immuno and chemo plus anti-VEGF therapy 4-drug combination, or we can combine immuno plus immuno as immunodoublet, and we can give immunodoublet with the chemotherapy. These are the various options available. So where does the atezolizumab fits in this schema? So talking about the atezolizumab approvals in non-small cell lung cancer, it was approved by the once the OAK data was there. Then 2016, it was approved as the second line therapy for metastatic non-small cell lung cancer. In the first line setting, it was approved with the IM power 150 in 2018. Then again, IM power 130 came in the first line setting. Then IM power 110 came in 2020. So I will be discussing basically IM power 110, IM power 130, and IM power 150. So these are the three trials which I'm going to discuss. IM power 110. This included non-squamous and squamous both type of non-small cell lung cancer. Number of patients almost 572, and there was 2 arms, ATI versus carbocisplatin plus pemetrexed in the non-squamous non-small cell lung cancer, and carbo or obliques with gemcitabine squamous cell carcinoma. The question here was is atezolizumab monotherapy a better agent than the chemotherapy in PD-L1 positive or PD-L1 selected chemotherapy naive patients? In IM power 130, the question was, is a steroid sparing chemotherapy regimen a better combination partner for atezolizumab? And in IM power 150, the question was, does the addition of atezolizumab to the standard of care bevacizumab plus paclitaxel and carboplatin add any clinical benefit? Is there improved clinical benefit if the bevacizumab is replaced with the atezolizumab? So IM power 110. This was the atezolizumab monotherapy versus chemotherapy in PDL selected first line non-small cell cancer. The stage 4 non-squamous or the squamous non-small cell cancer patients which were chemotherapy naive, PD-L1 selected, EGFR ALK negative, and the stratification factors were sex, ECOG performance status histology, and PDL extent of PD-L1 IC expression. The 2 arms was there, the atezolizumab 1200 milligram every 3 weekly, and the chemotherapy arm was for the non-squamous carboplatin or cisplatin along with the pemetrexed, and squamous it was the carbo-cis plus gemcitabine 4 to 6 cycle. In the chemotherapy arm, maintenance was for the non-squamous non-small cell cancer with the pemetrexed, and AT was given for 4 to 6 cycle. Then response assessment were done, and those who responded, atezolizumab was continued till progressive disease or loss of clinical benefit. So primary endpoint of IM power 110 was overall survival in the wild type population, excluding the patient with EGFR or ALK positive non-small cell. Key secondary endpoint was PFS, overall response rate, and duration of response. If we talk about the demographic and the baseline characteristic, it was balanced in both the arms, whether it was age, gender, white, Asian, never used tobacco or non-squamous histology. It was balanced in both the arms. So primary endpoint was the overall survival in the TC3 or IC3 expression subgroup, which was met. And you can see that median overall survival was improved by 7.5 months with the atezolizumab over the chemotherapy. The median overall survival in the chemotherapy arm was 13.1 months, and in the atezolizumab arm was 20.6 months. In the TC or IC3, that was PDL1 high, more than 50%. Tumor cells were positive for the PD-L1. In the same group like TC3 or IC3, at the updated analysis, there continue to be a clinical meaningful improvement in PFS with atezo versus chemotherapy with the PFS of 5.0 months in the chemotherapy arm versus 8.2 months in the atezo arm. At the 6-month PFS was 60% in the arm A with was atezo arm, and it was 38.3 months in the arm B. If we talk about the 12 months PFS, then it was 39 months in the atezo arm versus almost 50% down, 19.2 months in the chemotherapy arms. So at the updated analysis of the TC3 or IC3 wild type population, overall response rate was also improved with the atezolizumab versus chemotherapy. It was 40.2% in the arm A where the atezo was used, and it was 28.6% in the arm B where the chemotherapy was used. So OS benefit in PD-L1 high subgroup for atezo over the chemotherapy was maintained even when the samples were retrospectively tested with 22C3 or sp263. So these were retrospectively tested, and additionally pre-specified PD-L1 biomarker analysis was performed using the DECO 22C3 PD-L1 ISC assay and the Ventana sp263 PD-L1 assay. And we can see in all the graphs that atezo scored better than the chemotherapy arm, whether the tissues were tested by sp142 or 22C3 DECO or sp263 Ventana. So irrespective of the test used, atezo was consistently better than the chemotherapy arm in TC high group. So updated safety analysis was consistent with the data presented in the primary analysis, and no new safety markers were recognized. If we talk about the all-cause adverse effects, more than 5% difference between the arms updated analysis, then we can see that hematological and GI toxicity, which are more seen in with the chemotherapy, cytotoxic chemotherapy was same here, was seen more in the arm B where the chemotherapy was used, and inflammatory related itis like nasopharyngitis or arthralgia, pruritus or hypothyroidism, they were more seen with the immunotherapy, that is atezolizumab. So coming to the summary of IMpower 110, IMpower 110 is a positive study that demonstrated statistically significant and clinically meaningful improvement in overall survival in PD-L1 high, that is TC3 or IC3 wild type population versus platinum based chemotherapy with a hazard ratio of 0.59. And in the TC3 or IC3 wild type population, atezo showed meaningful improvement in the PFS, overall response rate, and duration of response versus chemotherapy. The safety profile of the atezo was consistent with the prior observation, and no new or unexpected safety signals were identified in this particular trial. Then coming to the next trial, which is IMpower 130, where the non-squamous non-small cell cancer, lung cancer were included. It is the phase 3 study of carboplatin and nab-paclitaxel with or without atezolizumab in the first-line advanced non-squamous non-small cell lung cancer. The schema was stage 4 non-squamous non-small cell lung cancer, chemotherapy naive, ECOG PS0 or 1. Stratification factor in this trial was sex, PD-L1 ISC expression, liver mets. Total number of the patient were 723. There was 2 arms. Arm A was the AT plus chemotherapy with the carboplatin nab-paclitaxel 4 to 6 cycle, followed by atezolizumab maintenance. Dosing was the standard. AT was given 20. Atezo was given 1200 milligram every 3 weekly. Carbo AUC 6 every 3 weekly. Nab-paclitaxel 100 milligram per meter square on days 1, 8, and 15 every 3 weekly. After completion of 4 to 6 cycle of chemo plus immunotherapy, atezo was continued till progressive disease or loss of clinical benefit. Arm B was chemotherapy only arm, carboplatin nab-paclitaxel 4 to 6 cycle, followed by switch maintenance to the pemetrexed was permitted in the control arm with the pemetrexed until progression. The co-primary endpoint was investigator assessed PFS in intention to treat wild type population, OS in ITT-WT, and secondary endpoints were PFS and overall survival in ITT. Investigator assessed PFS and OS in PD-L1 selected population, TC 2/3 and IC 2/3 versus IC 123. So there's the rationale of combining a chemotherapy with immunotherapy. We know chemotherapy kills once the chemotherapy kills the cells, the immunogens, antigens are released, and this makes the cancer more immunogenic. And in that way, chemotherapy and immunotherapy can work in a synergistic fashion. And the rationale for combining the Tecentriq with the nab-paclitaxel versus paclitaxel was, we know nab-paclitaxel is potentially steroid sparing. Paclitaxel is traditionally formulated in a solvent which is chromophore-EL to make it water soluble, and solvent-based paclitaxel may cause severe hypersensitivity reactions requiring pre-medication that includes the corticosteroid. So steroid are potentially immunosuppressive and may reduce the efficacy of cancer immunotherapies. So nab-paclitaxel is a solvent-free formulation that does not normally require steroid-containing pre-medication and therefore does not requires the immunosuppressive along with the immunotherapy. So IM power 1-3 baseline characteristics were generally well balanced between the arms and in all the groups. If we talk about the PDL tumor expression, then PDL high were around 20% of the patient and PDL low were around 28%, PDL negative were around 50% patients. So IM power 130 investigator assessed PFS was significantly improved with the addition of atezolizumab to the carboplatin paclitaxel with the atezo plus chemo in 6 months. PFS was 56.1% versus 42.5% in chemotherapy only arm, and at 12 months it was 29% versus 14% in chemotherapy arm. So median PFS, absolute improvement in median PFS was 1.5 months with the addition of the atezo. So PFS benefit was observed across clinically relevant subgroups in the ITT wild type population. This line is, I think, wrongly placed. So IPOM for 130 OS was significantly improved with the addition of the atezo to the carboplatin and nab-paclitaxel. At 1 year, atezo plus chemotherapy showed overall survival with 63.1 versus 50.5% in chemotherapy arm, and at 2 year, it was 39.6% versus 30%. In absolute improvement, there was a median survival of 18.6 months in chemotherapy plus immunotherapy arm versus 13.9 months in chemotherapy only arms. So IMpower 130 and OS benefit was observed across all the clinical relevant subgroups in the intensive wild type populations, whether it was liver mets or not liver mets. Also, overall response rate and duration of response were improved with the addition of atezo to the chemotherapy. Overall response rate in chemo-immuno arm was 49.2% versus 31%, 31.9% in the chemotherapy arm. They were the partial response, stable response. So safety summary, it was consistent with the other trials where the immunotherapy related side effects were seen in combination arm, and serious AEs treatment related adverse effects were more common in the combination of atezo plus chemotherapy with 23.7% versus 12.9% in the chemotherapy arm only. To summarize, IMpower 130, IMpower 130 met its co-primary endpoints like PFS and OS and demonstrated a statistically significant and clinically meaningful benefit in 4.7-month OS and 1.5-month PFS for the atezo plus chemotherapy in ITT wild type population compared with the chemotherapy alone. OS and PFS benefit were observed across all the PDL1 subgroups. Atezo plus chemotherapy had a safety profile consistent with AEs associated with single agent therapy, and no new safety signals were identified. The IMpower 130 results support the atezo plus chemotherapy as the treatment option for patients with advanced non-squamous non-small cell lung cancer. Coming to IMpower 150, they included non-squamous non-small cell lung cancer like IM 130. This is a phase 3 study of atezo plus chemotherapy and bevacizumab in first-line advanced non-squamous metastatic non-small cell lung cancer. The schema of trial stage 4 or recurrent metastatic non-squamous non-small cell lung cancer, chemotherapy naive, tumor tissue available for the biomarker testing, and any PDL1 IC status were included. So stratification factor here was sex, PDL1 IC expression, and liver metastasis. Total number of the patient in trial was 1,202 patients, and the co-primary endpoints were PFS in ITT and TEF-I and OS in ITT wild type population. There were the three arms. Arm A was atezo plus chemotherapy 4 to 6 cycle, followed by maintenance with the atezo in the responders. Arm B was ABCP, atezo plus chemotherapy plus bevacizumab, again 4 to 6 cycle, followed by maintenance with atezo plus bevacizumab. And arm C, where the carboplatin, paclitaxel, and bevacizumab was used for 4 to 6 cycle, followed by bevacizumab maintenance till disease progression or loss of clinical benefit. So baseline characteristics were well balanced between the arms, and 14% of the patient had liver metastasis at baseline, which were a stratification factor in IM power 150. And 10% of patients had EGFR mutation, and these patients were balanced across all the three arms. There was an approximate 50-50% split between the PDL1 positive and negative patients. So there was a significant OS benefit with the addition of the atezo in the ITT population arm B versus C, with drug chemo plus bevacizumab versus chemo, bevaci, and atezo was used. If we talk about the median OS, it was chemo plus biological agent, it was 14.7 months, and it increased to 19.51 with the addition of the atezo. OS at 12 months was 67% in the 4-drug combination versus 61% in 3-drug combination. At 18 months, the benefit continued to be there with 53% versus 41%, and even at 24%, benefit was there with 43% versus 34% with a hazard ratio of 0.8. So the improvement in the median OS was 4.5 months, and which is clinically meaningful. Also, the overall response rate and duration of response were improved in the ITT population. A high proportion of the patient responded to treatment with atezo plus bevacizumab plus chemotherapy with 56% response was there, versus in arm A with only chemotherapy plus atezo was 40%, and in without atezo chemo plus bevacizumab it was 41%. In PDL1 high with TCS3 or TCS IC3, the response was again significantly high in 4-drug combination with 69% response versus 62% in drug plus immuno, and drug plus biologic agent it was 49%. In PDL low, the difference was much more with 58% response rate in 4-drug combination versus 44% in the drug plus immunotherapy. So duration of response arm B versus arm C was 11.5 months 4-drug versus 6 months in the 3-drug combination. So OS benefit was observed across all the PDL1 subgroups in the ITT populations, arm B versus C, ABCP versus BCP in the TCS TCI. So median PFS was almost double with the 30 months in the ABCP group versus 15 months in the BCP group. So OS benefit was observed across all the PDL1 subgroups in the ITT population, PDL positive and PDL negative. Both you can see in the TC1, 2, 3, there was a benefit was seen, and even in the negatives, benefit was there, though benefit was limited. Coming to the efficacy in the C group, key subgroups like EGFR positive after the EGFR TKI progression, there was the 10% patient in each arms. So these were the number of patients. Total number of EGFR or ALK mutation 160 number of patient was there. EGFR mutation 124, and sensitizing EGFR mutation were 91. And sensitizing EGFR mutation with prior TKI therapy around 78 patients were there. These were the patient who has already received TKI and they progressed after the TKI. So we know there are limited options after the patient progresses on the TKI. So clinically meaningful PFS benefit was observed for the arm B versus arm C in patient with EGFR mutation positive or ALK positive non-small cell lung cancer. The PFS KM curve separated at around 6 months, and they keep on separating. So median PFS was 6.1 months in the chemo plus biologic agent versus 9.7 months with ABCP group. So OS benefit in patient with sensitized EGFR mutation. So there was continued clear separation of the curves and OS benefit with the addition of atezo to the bevacizumab chemotherapy arm A versus arm C, and arm A versus arm C. So OS benefit in patient with sensitized EGFR mutation with prior TKI therapy, there was a continued clear separation of the curves and OS benefit with the addition of atezo to bevaci and chemotherapy. Overall response rate and the duration of response were improved with bevacizumab plus atezolizumab plus chemotherapy in patient with EGFR positive non-small cell lung cancer. And efficacy in the patients who had the liver metastasis. We can see here that there was a clinical meaningful PFS was observed for the arm B, where the 4 drugs was used, versus arm C, where the 3 drugs was used in patient with liver metastasis at the baseline. Patient with the liver metastasis have clinical meaningful survival benefit with a median survival of 8.2 months in the ABCP group versus 5.4 months in the BCP arm. The OS benefit was observed in patient with liver metastasis with bevacizumab was added to the atezolizumab, and care comes separated early and is separated in the ABCP group. Also, the overall response rate and duration of response was more with the 4-drug combination as compared to the 3-drug combination BCP arm. Then patient with the bulky disease. So high bulky tumor burden was defined as a more than third quartile of the median, and low disease burden was less than third quartile. So if you see the high burden disease, there was the median OS was 15.5 months versus 10.7 months in the 3-drug regime. And in the low burden tumor, the response median OS was 20.3 months versus 17.1 months. So in a high tumor burden, response was difference was more significant. So the clinical benefit for the addition of the atezo to the bevacizumab CP was observed in a patient with and without bulky disease, regardless of the approach used to define bulky. This benefit was even more pronounced in high disease burden subgroups. So this 4-drug combination was well tolerated with the safety profile consistent with the known safety profile of each drug, and there was a higher proportion of treatment-related grade 3 to 5 AIs and AIs of special interest in arm B, where the 4-drug was used, and this was expected due to the additive effects of the 4-drug instead of 3. So we need to be very careful in selecting the candidate for the ABCP arm. So to summarize, IM power 1-3 atezo monotherapy in the high PDL expression, the both squamous and non-squamous, it was beneficial versus chemotherapy. And IM power 130 atezo plus chemotherapy in non-squamous histology, potential steroid sparing regime, PDL all comers, even in PDL expression 1 to 49% and less than 1%. Option in patient with comorbidity like renal dysfunction and uncontrolled diabetes, where the other immunotherapy drugs may not be as beneficial or as recommended. In IM power 1-3 atezo plus bevacizumab and chemotherapy combination in non-squamous histology, PDL all comers. However, the significant benefit was seen in those patients who has progressed on the TKI where limited options are available. And if the PS permits, then the ABCP is the regimen to go. Then patient with the liver metastasis and those patients who has a bulky disease.
Thank you, sir. Thank you for your excellent talk.
So I'll stop my talk here. Thank you. Thank you for patient sharing.
Thank you, sir. Thank you for the excellent talk.
Okay. So for the next talk, I would like to invite Dr. Vibhor Sharma. Is there Dr. Vibhor? Dr. Vibhor is the head of the medical oncology, hematology, and bone marrow transplant at Yatharth Group of Hospitals in Greater Noida. And Dr. Vibhor is going to give talk on the meeting unmet needs in MET exon mutation in non-small cell lung cancer. Dr. Vibhor, please, over to you.
Technical team, please can you unmute viewer, sir?
Yes, Rishabh sir.
Please unmute Vibhor, sir. He's asking for that.
Yeah, am I audible now?
Yes, sir, you are audible.
Okay.
Yeah,
Okay,
yeah.
fine. So I thank the organizers for giving me this opportunity. I will be speaking today on meeting unmet needs in MET exon mutation in non-small cell lung cancer. Next slide. So this is the evolution of therapy in lung cancer. So when we see a patient of lung cancer in the clinic, first of all, we find out whether it is a non-small cell or a small cell. When further among the non-small cell histologies, we try to find out whether it is squamous, non or adeno. And then most importantly, we look at the molecular pathology. That is, what are the driver mutation, if any. And we also look at the PDL1 expression levels. So these are a list of driver mutations that are that we commonly look for in our practice, and they're also approved in NCCN to be looked for in all patients of non-small cell lung cancer, namely EGFR, AL, CROS1, BRAF, RET, MET, NTRK, and so these are the list of targeted mutations that we are looking for. Next slide. So all patients of non-small cell lung cancer, we must assess for any actionable biomarkers before their first-line therapy, as well as throughout their treatment course. Next slide. Biomarkers can be assessed by two means. The traditional method was the tissue biopsy, and now we also have liquid biopsy, in which circulating tumor cells or cell-free DNA is picked up, and we have various modalities to look at the various kinds of mutations, namely IHC, FISH, RT-PCR, and next-generation sequencing. Next slide. So there are two ways of testing for these mutations. One is we can do sequential testing. Another method is to do upfront NGS. The benefit of doing upfront NGS is that the turnaround time will be shorter, although it will come at a higher cost. So for patients who can afford upfront NGS, it covers all the mutations in one go. But for those patients where upfront NGS is not affording, so still we go for sequential testing with the common mutations first, EGFR, AL, CROS1, and PDL1 testing. So coming to the topic for today, MET exon 14 skipping mutations. So CMET is a hepatocyte growth factor receptor. It's a tyrosine kinase receptor that is involved in cell survival and proliferation. Various oncogenic driver genomic alterations can take place in MET, and these include MET exon 14 skipping mutations, MET gene copy number gain or amplification, and MET protein overexpression. So generally, the MET exon alterations do not overlap with other mutations like EGFR, ALK-ROS1, and BRAF. It's also notable that MET exon 14 skipping mutations and MET amplification can sometimes occur together. NGS is the preferred testing modality for MET exon 14 skipping mutations, and RNA-based NGS has improved detections. IHC should not be used to detect MET exon 14 skipping mutations. When using NGS, a copy number of greater than 10 is consistent with high-level MET amplification. MET exon 14 skipping mutations are found in 3 to 4% of adenocarcinoma lung and in 1 to 2% of squamous cell CA lung. And these mutations are more frequent in older women and those who have never smoked cigarettes. Next slide. Yeah, I've covered this. Next slide. Yeah. So coming to MET exon 14 mutations, how to look for them? There are two methods, liquid biopsy and tissue biopsy. So in the study which looked at tepotinib, both the methods were utilized in that particular study, the VISION trial, right? But if we are using capmatinib, then only tissue biopsy is the approved modality. So when it comes to the comparisons, obviously liquid biopsy is easily accessible. It's a non-invasive test with no complications, and it can be done for all patients. However, the sensitivity of testing is higher for tissue biopsy as compared to liquid biopsy for MET exon 14 skipping mutations. Next slide. So patients with MET exon skipping mutations are usually elderly. They have got higher PD-L1 expression, and they are usually elderly females who have never smoked. Next slide. These patients, if treated with traditional immunotherapy or chemotherapy, have got poor outcomes with the PFS with immunotherapy of only 2.69 months. Only 16% of patients will likely respond to single-agent immunotherapy. And with chemotherapy also, they have got poor survivals. The median survival with chemo-treated patients is 8.1 months in MET exon 14 skipping mutations. Next slide. So there are three types of MET inhibitors. They are defined by the structure and their mode of MET binding, type 1, type 2, and type 3. But it is notable that all the NCCN approved drugs for MET inhibitors are all in the type 1, namely tepotinib, capmatinib, and crizotinib. Next slide. So when it comes to the phase 2 clinical trials with MET inhibitors, we'll look at mainly the two MET inhibitors, tepotinib and capmatinib. Savolitinib is a drug which is approved in China. This is not there in the NCCN guidelines, neither is it available in our country. So when it comes to tepotinib, it was looked at in the VISION study, which was a phase 2 study. Capmatinib, the study looking at it is called Geometry study. That was also a phase 2 study. In the VISION study, where tepotinib was evaluated, both liquid biopsy and tumor biopsy was allowed. Whereas in the trial of capmatinib, only tumor biopsy was allowed. So both these studies, the patients enrolled should have been naive to MET inhibitor. The tepotinib study included patients who had received up to 2 lines of prior therapy. If we see, the median age was 72 and 71 years. This is consistent with the age group in which MET exon 14 is usually found. And ECOG PS 0 and 1 were taken. The histology in both the studies was 80% were adenocarcinoma, and almost remaining 20% was squamous and other histologies. Brain metastasis was allowed in both the tepotinib and capmatinib studies, and they were around 18% and 16% respectively. Next slide. So in the tepotinib study, there were 313 patients enrolled. In capmatinib, 160 patients were enrolled. Both these drugs, tepotinib as well as capmatinib, have got intracranial penetration, and patients with brain metastasis were included in both the studies, and they showed responses in both the studies. The dose of tepotinib is 450 mg OD, whereas the dose of capmatinib is 400 milligrams twice daily. If we look at the responses in the tepotinib study, looking at those patients who were tissue biopsy positive. So the median OS was 29.7 months, median PFS was 15.9 months in the first line, and the median overall response rate was 58.6 months. In the capmatinib study, in the first line, the overall response rate was 68.3%, OS was 25.5 months, and PFS was 12.5 months. In second line and beyond, in the tepotinib study, overall response rates were 49.5%, OS was 20.4 months, and PFS was 11.5 months. Whereas in capmatinib, the overall response rate was 44%, OS was 13.6 months, and PFS was 5.5 months. So these two drugs look to be comparable with each other. Next slide. So this was the VISION study design. Patients with advanced or metastatic non-small cell lung cancer who had MET exon 14 skipping mutations detected either by liquid biopsy or tumor biopsy were taken. They should not have received previous therapies targeting the MET pathways, and they could have received 2 or less lines of prior therapy. Total 313 patients were enrolled, and the dose included was 450 mg OD. The primary endpoint of this study was overall response rate. And if we look at the patients, we find that almost 30% of these patients were Asian patients also, and approximately 18% patients had brain metastasis at baseline. Next slide. So 42% of these patients in the tepotinib trial were found to be MET exon positive by tissue biopsy. 21% patients had both liquid and tissue biopsy done, and 36% patients had got only liquid biopsy done. And the study included patients all across, both in North America, Europe, and Asia. Coming to the efficacy, next slide. So if we look at the in treatment-naive patients, looking at the efficacy of tepotinib, overall response rate was 58.6%, and PFS was 15.9 months, and OS was 29.7 months. This is those patients who were treatment-naive and who had tissue biopsy done. Next slide. In the second-line treated patients who were again positive by tissue biopsy, the overall response rate of tepotinib was 49.5 months, OS was 20.4 months, and PFS was 11.5 months. Next slide. If we look at the Asian subset of patients enrolled in the tepotinib study, the OS was 32.7 months in the first line and 23.7 months in the second line, which was quite decent. Next line. Next slide. If we look at the intracranial activity, 88.4% patients on the tepotinib arm had intracranial disease control, and 66.7%, almost two-thirds, had intracranial responses, with 20.9 months of intracranial PFS was obtained. Next slide. Previous slide, please. Previous slide. Yeah. So if we look at the two drugs which are approved in NCCN, tepotinib and capmatinib, so the daily dose of tepotinib is 450 mg once daily, whereas in capmatinib, the ideal dose is 400 milligrams twice a day. Next slide. So we can dose reduce in case of adverse reactions. Tepotinib, we can reduce to 225 mg once daily. And for capmatinib, the first dose reduction is 300 mg twice daily, and the second dose reduction is 200 mg twice daily. Next slide. Coming to the adverse effects, the most common adverse effects of MET inhibitors, and which is a class effect, is peripheral edema and pleural effusion. We can see that they are seen in almost two-thirds of the patients. Edema is noticed. Apart from that, patients can have nausea, increase in creatinine clearance, transaminitis, fatigue, and these adverse events have led to treatment discontinuation in the trial population in 14.7% and 16.1% patients respectively. Next slide. So dose modifications can be done in the tepotinib study. For dose modification in case of adverse events, the dose can be reduced from 450 mgod to 225 mgod. And apart from that, other simple conservative measures for relief of edema like limb elevation, use of diuretics, use of compression stockings, etc. can be done. So coming to the concluding slide. So MET exon 14 skipping mutation patients, they should be treated with MET targeted therapies. And we have tepotinib, we have capmatinib, and we also have crizotinib, which can be utilized. And all the three drugs are approved in NCCN guidelines with preference for tepotinib and capmatinib. So these studies, the studies which have led to these approval of these agents are all phase 2 studies, and they have shown longer PFS, longer OS, and better ORRs as compared to, although these were single arm studies, but if we look at the responses to chemotherapy or immunotherapy, so treatment with targeted therapies in patients having MET exon 14 skipping mutations, as well as patients with MET amplification yields better results. Also notable point is that these agents show response in patients with brain metastasis also. So with this, I would like to thank you. Next slide. And thank you for your patient listening.
So please unmute
Sir,
your
you are
mic.
Oh, sorry, I was muted. Thank you, Dr. Vibhor, for such a elaborate talk. And this is the topic which normally we don't see or hear in the meetings. So thank you for taking up this topic and throwing the light on this rarely discussed topic. Thank you, Dr. Vibhor. And for the next talk, I would like to invite Dr. Shaunak Valme. Dr. Shaunak is the medical oncologist from Bhopal and working as a medical oncologist at Jawaharlal Nehru Cancer Hospital and the Research Center. So, Dr. Shaunak, please. Dr. Shaunak is going to talk on the targeting HER2 in the non-small cell lung cancer. Over to you, Doctor.
Yes, sir. Good evening. Thank you for the kind invite. So, I was listening to the previous lectures. We had a very vast array of knowledge that we gained. So today, I'll be speaking about HER2 in non-small cell lung cancer. So we know that HER2 amplification and overexpression are well documented in CA breast. And anti-HER2 therapies are also well documented in breast, gastric, as well as upcoming therapies in colon and now lung. In lung, however, there's always a difference between the overexpression of HER2 and the amplification or the mutation of HER2, which is why we haven't seen HER2 therapies work as well as we see in CA breast. So coming to the HER2 mutation, we can see it's only a minor category of non-small cell lung cancer, only 2% that are HER2 positive. In the Indian population, it is less than 1%. So coming to the differences between the mutations versus the amplifications and the protein overexpressions. So protein overexpressions are obviously the most common. IHC3 plus can be seen in 3 to 6% of cases. But it is not considered actionable, and the lack of therapeutic response by the existing anti-HER2 drugs is evidence of that. HER2 amplifications can be seen in 10 to 20% of patients, and they are a known resistance mechanism to the EGFR positive disease, and they are detectable by FISH or NGS. HER2 mutations are solely detected by NGS and are seen in 2 to 4% And this is the category that are the driver mutations or the actionable mutations. They're usually mutually exclusive from the common mutations that we see of EGFR, ALK, and KRAS. And association of a co-mutation of HER2 in the presence of others are associated with a poorer prognosis. The impact of HER2 overexpression has also been shown to be associated with worse survival. In a meta-analysis of 40 studies where more than 6,000 patients were enrolled, HER2 overexpression was a poor prognostic factor for adenocarcinoma in the early stage. HER2 mutation, as we saw, ranges between 2 to 4% in terms of incidence, and they're more common in Asian females and non-smokers. The method to detect mutation is RT-PCR or NGS. The most common mutation occurs in the exon 20, which is a duplication or insertion at codon 776, accounting for 80 to 90% of HER2 mutations. Other rare mutations can also be seen, which are targetable. So previously, these mutations were mutually exclusive. But a European study revealed concomitant EGFR mutations, ALK translocations, and ROS translocations concurrent to HER2 mutations in some patients. The importance as of now is unknown, but few do suggest it has a negative prognostic effect on OS. In breast cancer, HER2 overexpression correlates with HER2 amplification, but this is not observed in lung cancer. Nakamura et al. In 50 cases of surgically resected non-small cell lung cancer saw that HER2 overexpression was detected in 26% of the cases, whereas amplification in only 2%. In another study by Hirsch et al., only 12% of the specimen had corresponding IHC and FISH positive results. So there is no clear association between HER2 mutation as well as overexpression. And therefore, to ascertain whether HER2 is the driver mutation, NGS is definitely required. So this study, recent study showed that HER2 overexpression is associated with lower survival rates, whereas HER2 amplification did not appear to affect survival. As we can see in the graph on the right, those that had HER2 overexpression had a significantly shorter OS as well as DFS, as you can see in the green Kaplan-Meier curve. Numerically, it was 2 years versus 2.6 years in the HER2 wild type. HER2 mutation also showed shorter survivals than those tumors that were driven by EGFR and ALK. Again, a similar bar plot that we see is that in the role of driver mutation positive, we know that immunotherapy responds pretty less, which is why we don't use immunotherapy as a frontline or even a later line option as far as possible in EGFR and ALK and ROS. The similar concept has been seen in HER2, where the objective response rates to ICI monotherapy was barely 7% and a PFS of 2.5 months. So monotherapy versus combination chemotherapy versus plus immunotherapy showed that in HER2 mutation, the objective response rates was about 52%. And in the post-first line setting, it was 16%. This highlights the need of having specific anti-HER2 agents for HER2 mutated lung cancers. And that is where we come to the point today. So we know that HER2 is a part of the EGFR group of receptors. EGFR is the HER1. So while targeting HER2, we have TKIs which we have used in CA breast, such as lapatinib. Other TKIs that have come up, mobocertinib, pyrotinib, and poziotinib, which inhibit the intracellular tyrosine kinase domain. But mobocertinib recently has had its approval withdrawn. Afatinib, which is actually a EGFR TKI, has shown to have some impact on HER2 mutation as well. So phase 2 trials where TKIs have been used against HER2, we can see that the highest response rates have been seen with pyrotinib and bosutinib, with a median PFS of about 5 to 6 months. But I've had one or two patients with whom I've given afatinib as a maintenance therapy post first line chemotherapy, and they've done fairly well with a PFS of about 4 to 6 months. So this is at least one thing that we can try in our setting, considering that we do not have these molecules available to us as of now. Neratinib has been tested, but the objective response rate is very poor. Coming to the monoclonal antibodies, the paradigm antibodies are trastuzumab and pertuzumab, but again, they have not been shown to be very effective in non-small cell lung cancer. As we can see, there are phase 2 trials, but the way that we give trastuzumab and pertuzumab for IHC 3+, you can see this specific study here was a phase 2 study, and the median survival for IHC 1+ was in fact the highest compared to 2+ and 3+. So again, this shows that IHC, or the overexpression of HER2, does not correlate with mutation and is not the best indicator for the choice of anti-HER2 agents, and that is why we need the NGS for our patients. So other drugs, TDM1 as a antibody drug conjugate, this is the one that has shown the highest response rates before TDXD came into play. So this 44% response rate was seen in HER2 mutation positive by NGS. Again, you can see that it was also tested in the HER2 overexpression category, but it had a pretty poor objective response rate. So the antibody-based strategies, people have tested the combination of trastuzumab, pertuzumab, and docetaxel. A fairly even response of 30% of objective response rate was observed. Median PFS of 6.8 months, OS of 17.6 months. But again, the argument against this is that single agent docetaxel in the second line setting also works wonders, and the addition of ramucirumab to docetaxel is also a good combination strategy, irrespective of the mutation, because 6.8 months is probably not very sustainable. That is where the antibody drug conjugates come into play. We have these two targets now, TDM1 and TDXD. So TDM1, which was the initially tested in the phase 2 study, saw a objective response rates of only 7% in those that were HER2 overexpressing or mutants. Another study showed a 20% response rate. But if we go to NGS testing and we find those patients who are actual HER2 mutants or amplified, you get objective response rates of around 50 to 55%. And you can see the waterfall plots here that there is some responses. Median PFS of roughly 5 months is expected. So this is the layout of anti-HER2 treatments in non-small cell lung cancer. We have studied that HER2 overexpression occurs in up to 30% of patients. Cisplatin-based chemotherapy and pemetrexed-based chemotherapy give fairly 30 to 40% response rates. Trastuzumab plus chemotherapy does have a response rate, but again, it is not very it is not approved and not very prominent as a regimen. As far as the TKIs are concerned, afatinib does give some response rates. Pyrotinib and bosutinib are there, but again, not available in our country, so I don't have the idea regarding these molecules. But TDM1 and TDXD are the ones that we are going to be discussing more of now. So, as per the evolution of the antibody drug conjugates, what is the difference between TDM1 and TDXD? So, first and foremost, the drug conjugate is different. We have maytansinoid in TDM1 and deruxtecan, which is a topoisomerase 1 inhibitor in TDXD. You have a much higher payload in TDXD, 8:1 compared to 3.5:1. You can see the 8 drug conjugated to the antibody compared to just 3 or 4 in the TDM1. Most importantly, it has a bystander effect and it is selective cleavable linker. So what this implies is that once if the linker is cleaved, it is better internalized by the tumor cells and not in the healthy tissue circulation. And the intracellular stability of the payload is better and it gives a better bystander anti-tumor effect. So the Destiny Lung 1 was one of the earliest studies that assessed the evolution of TDXD on metastatic non-squamous non-small cell lung cancer patients who had relapsed or were refractory to standard treatment. So they took 2 cohorts. One was obviously the IHC overexpressing cohort, and the second cohort was HER2 mutated cohort. That time again it was a dose. The dose was also at 6.4 mg per kg, which we now no longer use. The primary endpoint was the objective response rate. The median age for these patients were about 60 years of age. Only 25% were from Asia, and median number of therapies that they had used was 2. Platinum-based chemotherapy, almost all the patients had received. Prior HER2 TKIs in 14% of cases. So this was an extensively pre-treated patients with a median of 2 to 3 lines of therapies, and an objective response rate of 24.5% was observed, with no apparent difference as per the HER2 expression. The median PFS was 5.4 months, OS of 11.3 months, and ILD, which is a very important and a specific side effect to TDXD, occurred in 16.3%. In the HER2 mutated cohort, we can see a much higher objective response rate of 55%. Median PFS was longer at 8.2 months and a median OS of 17.8 months. ILD was also more common in these patients at 26.4 months. So, interstitial lung disease is the most important complication that we have to be aware of for TDXD. Besides that, grade 3 or higher, most patients, 15% of patients had neutropenia and anemia as the most common adverse effects. So, with respect to TDXD and interstitial lung disease, there were 2% of patients who developed grade 5 toxicities. Most toxicities were grade 2 to 3. But, we have to be aware of that, and every 6 to 8 weeks, HRCT or a CT scan or a contrast CT scan to evaluate the assessment of interstitial lung disease is now advised. The majority of patients were grade 1 or 2 and were reversed. The median time to onset of ILD and pneumonitis was 140 days and a median duration of 43 days. And most of them received more than 1 dose of glucocorticoids. And at the time of cutoff, majority of the cases had fully resolved. So the FDA did grant the accelerated approval for trastuzumab deruxtecan in August 2022. This comes to now we come to Destiny Lung 02, which was again a dose study of 5.4 versus 6.4 mg per kg. But this time they were only assessing in those that were HER2 mutated and not overexpressed. The primary endpoint was still the ORR, and the secondary endpoints of safety analysis and PFS and OS were also considered. So there were more patients in the TDX in the 5.4 mg per kg arm. The objective response rate was almost 30% in the 5.4 arm versus only 12% in the 6.4 mg per kg arm. Complete responses were similar. Disease control rate was higher in the TDXT 5.4 mg per kg arm. and median duration of response was not reached. The mean best change was again higher in the 5.4 mg per kg arm. With respect to previous therapies, 37% had previous platinum-based therapies and PDL1 therapies. 15 patients had previous platins but no immunotherapies. Compared to the 6.4 mg arm, where 22 patients had platinum as well as immunotherapies, and only 6% had platins but no immunotherapies. Drug-related ILDs, as we can see, were much lesser in the 5.4 mg per kg arm compared to 6.4. So based on this, as per the safety profile, 5.4 mg per kg is the final set dose for TDXD. So the 5.4 mg per kg dosing yielded meaningful responses in those that had received more than one prior systemic therapy. A more favorable safety profile and a lower incidence of ILD with the 5.4 mg dosing. And early detection and management of pneumonitis is critical, for which every 6 to 8 weeks an HRCT or a CT chest is advised. So obviously now we come to a stage where we would want to see the effect in a first line setting. So Destiny Lung 04 is comparing first line TDXD versus standard of care for unresectable, locally advanced and metastatic non-small cell lung cancer with HER2 mutations of exon 19 or 20. Dose is defined as 5.4 mg per kg every 3 weekly, and the standard of care is platinum-based chemotherapy and including immunotherapy. Destiny Lung 3 was a phase 1 was a phase 1 dose escalation strategy of metastatic unresectable non-squamous HER2 positive non-small cell lung cancer. And again, this was again for the HER2 overexpressed and not the HER2 mutated. So the dose escalation strategy has used multiple arms where the partner of immunotherapy as well as platin has been used. Cisplatin and carboplatin both have been used. And in those expansion cohort where the number of patients has been increased and the primary endpoint is the safety. So the part 1 will be for the second line and third line patients, whereas for part 2, the dose expansion cohort will be for the untreated first line setting. So the newer anti-HER2.
I request you to please conclude your talk.
Yes, last slide. So so the new anti-HER2 drugs are still under development. There are many other monoclonal antibodies and ADCs that are coming into play. But for now, our takeaways are that HER2 alteration in non-small cell lung cancer is heterogeneous. Prognostically, it is suggestive of worser outcome. Therapeutically, you need to treat as per the alterations. For overexpression and amplification, there is no specific data to suggest that we should be using anti-HER2 therapies. But for HER2 mutations, TKIs or TDM1 and now TDXD may be used. Trastuzumab deruxtecan is the only approved therapy, but however, this is in the second line setting, and studies are ongoing with different strategies and may change the future as we have seen in CA breast. Thank you.
Thank you, Dr. Shaunak. Shaunak, you presented very well, and I think I'm audible.
Yes, sir.
Yes, sir,
sir.
you are.
Yeah, sorry, sir. Video is not on. Shaunak, your presentation was very well, starting from the differentiation between the two overexpression, mutation, and the amplification, and the role of anti-HER2 drugs in the lung versus breast cancer. It was really very informative. And as the more and more ADCs are being studied, we are surely going to see more drugs in the lung cancer for the HER2 mutation positive patients. Thank you once again. And for the next talk, which is on the treating KRAS mutant non-small cell lung cancer, I would like to invite Dr. Mukesh Patekar. Dr. Mukesh is the unit head at medical oncology at Artemis Hospital, Gurugram. Over to you, Dr. Mukesh Patekar.
Thank you, sir. And good evening, everyone. As we are 30 minutes late, so I'll quickly start my talk. So, topic assigned to me is treating KRAS mutant non-small cell lung cancer. We all know that it is the most common cancer which has the highest lethality. And this KRAS, it is a well-known the oncogene which has a most common gain of function alteration. Multiple studies have shown there is at least 30% of lung adenocarcinoma in Western population, and around Asian population around 10 to 15% patients do have KRAS mutated non-small cell lung cancer. Basically, it is a GTP and GDP binding protein, which is a member of RAS protein family. It has a diverse mutations in the KRAS in terms of the lung cancer concern. Basically, they are predominantly happens to be in adenocarcinoma, even though there are some small cases of squamous cell, they do have some rarely KRAS mutation. Mutant KRAS with different amino substitute may also suit the distinct biological behavior, and I will, there are some slides, they will just point out the difference between what is the clinical relevance of KRAS mutation? It tends to be more common in women along with the younger age. And it also has a distinct molecular fingerprint on KRAS in terms of the smoking. Like G12D, they are more frequent in the never smoker. And when you talk about transvergent mutation like G12C or G12V, they are more common among the former or current smokers. And smokers, they tend to have a genetically more complex KRAS mutant tumor with higher tumor mutation burden and a higher frequency of major co-occurring mutation like T53 and STK11. There is the strongest proof of KRAS being narrative proof of concept that it is a negative prognostic factor, as it was studied by the Maxcross et al., who conducted meta-analysis of 53 studies. And it has found that the KRAS mutation was correlated with significantly worse prognosis as compared to those who don't have KRAS mutation. Because of high frequency of non-small cell lung cancer, KRAS mutation, like I said earlier, it is a appealing target. However, over the period of time, it was considered to be undruggable due to its exceptionally high affinity to the GTP binding, as it occupies the all potential binding site with extremely high affinity. So this is the timeline for the KRAS mutation in terms of the lung cancer. There were multiple studies of MEK inhibitor, or there are studies, they were all negative studies like MEK inhibitor, mTOR inhibitor, and we have studies of, again, sorafenib have been also tried, HSP90 inhibitor. With this prolonged journey from 1967 to year 2021, now we have this molecule AMG 510. It was studied, and which also known as a sotorasib. I will take you through the data of this molecule in context to this molecule. So this is the phase 2 CodeBreak 100 study, which has shown the overall survival and exploratory subgroup analysis of sotorasib in pretreated KRAS G12C mutated non-small cell lung cancer. So it is G12C is found to be in 13% lung adenocarcinoma. The CodeBreak 100 trial was phase 2 first-in-class trial of first-in-class highly selective irreversible RAS inhibitor sotorasib. And on May 28, 2021, it has received accelerated approval for the treatment of KRAS mutated G12C mutated non-small cell lung cancer who has received more than one line of systemic therapy. There are two FDA approved tests. One is Quagen TheraScreen KRAS PCR kit, and we have Garden 360, which can be done on the blood. G12C mutation, it is a hallmark of damage from cigarette smoke. It is the most common in the lung cancer. Regarding the sotorasib, it is a novel first-in-class. It has irreversible inhibition of G12C by looking at this inactive GTP-bound state. Coming to the CodeBreak 100 trial, it is a phase 3 study where the patients with KRAS G12C mutation by central testing progress on a 3 or less prior standard therapies with no active CNS disease were randomized. It was phase 3 single arm, so they were given sotorasib 960 mg orally until disease progression. The primary endpoint was overall response rate, and there were secondary endpoints like duration of the response, disease control rate, PFS, TPR, OS, and safety. So these are the primary endpoint. Confirmed overall response rate was 37.1%. Predominantly patient had a partial or stable disease. Very few had a CR, even though they were in third line setting. Coming to the duration of the response, it was 80.6%. Median duration of the response was 11 months. This is the median OS, it was 12.5 months. This is the exploratory analysis of efficacy by molecular subgroups, like it based on the whether the P53 present or not, STK11 and KIP1. Those patients who had a wild or mutant type, there was not much difference between the P53 and STK11. However, there was a steep difference between KIP mutation and a wild type in terms of this sotorasib efficacy. This efficacy was observed regardless of PD-L1 expression, level of TMB, and or presence of co-occurring mutation. And this is the PD-L1 substratification less than 1%, 1 to 49%, and more than 50%. Here we can see that if they are less than 1%, overall response rate was 48%. If more than 50%, there was 42, and in all evaluable patients, it was 42. Even TMB lower wise, there was not much difference. The co-mutation noted arising as a potential predictive markers in KRAS mutated lung cancer, like the most commonly studied are T53, STK11, and KIP1. There was a difference in the signaling immune feature metabolic programming as per the preclinical model, and they have some prognostic as well as potentially predictive in terms of immunotherapy. So this is the safety data on this CodeBreak trial. The any grade toxicity was 69.8%, grade 3 was around 20%. The most common was diarrhea, nausea, transaminitis, and vomiting. So treatment-related adverse events were generally low grade and manageable. There were around discontinuation around 7.1 patient, and dose modification was required in 22% patient. There were no fatal treatment-related adverse event. So to conclude, CodeBreak 100 trial, it showed continued durable clinical benefit of sotorasib in a patient previously treated KRAS G12C mutated lung cancer, even after 15 months of follow-up. The median OS was 12.5 months, PFS was 6.8 months, with overall response rate of 37.1 months. This clinical benefit was observed across the patient subgroup, including those of baseline characteristic and molecularly defined subgroup from exploratory analysis. The clinical benefit observed with STK11 mutated tumors known to associate with the inferior outcome as compared to standard systemic therapies, and profile was low grade and it was manageable. So this is the another phase 3 randomized study, CodeBreak 200, where the sotorasib was compared with docetaxel in previously treated advanced non-small cell lung cancer with G12C mutation. In this, it was compared to the docetaxel, at least first-line systemic therapy. It could be the platinum-based doublet and checkpoint inhibitor, either as a one line of therapy or individual lines with preserved perform status. And it was given standard 21-day cycle on the primary endpoint of PFS. So results of the study was the improved PFS in tune of 5.6 months as compared to docetaxel 4.5 months. Lower than expected PFS of sotorasib from this phase 3 trial opened us opportunity for other G12C inhibitor to join the field. And now we have another molecule on the horizon, that is adagrasib, which also has a potential for advanced non-small cell lung cancer with G12C mutations. So this Crystal-1 trial, it is also has a new cohort with G12C and STK11 co-mutation. So in December 2022, FDA has given accelerated approval for this adagrasib and who have received more than equal to one systemic therapy. So this is the data for adagrasib, and here you can see that this waterfall plot shows the majority of patients were having the partial response, along with the few of the patients having the stable disease, as we have seen with the sotorasib. The overall response rate of 48, disease control rate 89%, median PFS 6.5, and median OS was 12.6 months. In terms of the toxicity, as like sotorasib, diarrhea, nausea, vomiting was more common, followed by the transaminitis. There were around 52 patients had a grade 1 and 2 treatment adverse event. 2 patients had a grade 5 toxicity. One was pneumonitis and cardiac failure. 50% required dose reduction, and 7% patient did require discontinuation because of toxicity. This is the multi-center transgenetic analysis of RAS and co-mutation advanced non-small cell lung cancer, where KRAS codon 13 had unexpected bias with NF1 mutation, and this NF1 co-mutation may signal improved OS related to the KRAS mutated patient. So there are these emerging options in a KRAS mutated lung cancer, as we have 2 molecules with KRAS G12C inhibitor for mutation, apart from standard chemotherapy and PD-1 inhibitor. So coming to the discovery and approval of sotorasib and adagrasib, it's opened up the opportunity to find a better other protein to target these mutations. G12C is one of the several key KRAS mutation found in cancer cell. There are other 2 most common mutations we already see in clinical practice, G12D and G12V. Sotorasib and other G12C inhibitors, they work permanently by locking KRAS G12C in off position. However, G12D and G12V can't be targeted the same way because they have a different chemistry as compared to G12C. There are several G12D inhibitors are in the development. NCR's RAS initiative as well as others have also made progress designing the pan-KRAS inhibitors, a drug that works against the several KRAS mutant protein, and in future we might get some other molecules in our kitty. With this, I'd like to end my talk. Thanks for opportunity, and over to the organizers.
Thank you, Dr. Mukesh. Your talk was really very systematic and informative. Thank you so much. So for the next talk, I would like to invite Dr. Kapil Goel. Dr. Kapil is the heading the Rajiv Gandhi unit, South Delhi unit, Rajiv Gandhi Cancer Institute, and he'll be talking on the treating BRAF mutant non-small cell lung cancer. Dr. Kapil, please.
Thank you so much, sir. Just give me a moment. I'm sharing my slides.
Sure.
So somehow I'm not able to share my slide. Can somebody from the technical team share my presentation? Yeah. Hello. Okay. Next slide, please. Good evening, everyone. Thank you, sir, for providing me this opportunity. In the interest of time, I will be keeping my talk crisp. So to objective is to introduction of BRAF and MAPK pathway, how the different BRAF and MEK inhibitor have been coming in the picture, what is the rationale behind combination of these two, what is the clinical data, and what are the adverse events related to BRAF and MEK inhibitor. Next slide, please. So this is the MAPK pathway in which we know a ligand binds to transmembrane receptor, that is RTK, and downstream it activates the RAS, which is upregulates the RAF, then MEK and ERK, and eventually it gives a proliferation, growth, and survival signal to the nucleus. Next slide, please. So now we have to see what are the incidence of BRAF mutation according to the tumor type. So highest incidence is actually seen in the hairy cell leukemia, which is practically defined by presence of BRAF V600E mutation. More than 95% of the HCL are actually BRAF mutated. If BRAF mutation is not found, it is actually called as atypical hairy cell leukemia. Next common is melanoma, which is seen in more than 50% of the cases, followed by anaplastic thyroid carcinoma, which is seen in 20 to 50% of the cases, followed by low-grade glioma. NSCLC is actually one of the tumor which has low prevalence of BRAF mutation. Only 1 to 5% cases are affected. Next slide, please. So these are the various mechanisms what is kind of mutation that can happen in the BRAF pathway. So with the BRAF V600 pathway, more common non-B, then other pathways are non-V600E mutation, and other is the CRAF pathway that is also affected in some tumors. Next slide, please. So most common mutation is actually V600E mutation, and it is more common in the non-smoker and females, and it has a higher kinase activity compared to melanoma. But non-V600E mutation are seen in the older population and those who are heavy smoker, and there is no overlap with other mutations, which is sort of mutually exclusive with other driving mutation like EGFR and ROS. And typically they have been characterized by poor response of platinum-based chemotherapy. Next slide, please. BRAF inhibitor various. Next slide, please. So if we look at the various BRAF inhibitors, we know they act at different levels of BRAF pathway inhibitors. So there are different drugs which act at the different levels. So one is the RAS inhibitor, in which Dr. Mukesh just talked about a few of them. Then we have RAF inhibitor, in which the prominent drugs are vemurafenib, dabrafenib, and corafenib. And if we look at MEK inhibitor, tramtinib, cobimetinib, and binimetinib, which are exclusive ones, and ERK inhibitor under under evolution under the research. Apart from that, a few molecules like regorafenib and sorafenib also have some kind of anti-RAF activity, although they are multi-kinase inhibitors, so it is not exclusively BRAF. Next slide, please. If we look at the various BRAF MEK inhibitors, so general dose is vemurafenib, which is 960 mg, dabrafenib 150 mg, and corafenib 450 mg. Both of them to be taken twice a day, while encorafenib is a OD dose. If we talk about the MEK inhibitor, cobimetinib is a 60 mg tablet daily. Tramitinib is 2 mg, and binimetinib is 45 mg twice a day. All of them to be taken per orally with or without food, except for dabrafenib, which is to be taken empty stomach. Next slide, please. So based on experience and success of BRAF inhibitor in melanoma, similar studies were performed in SCLC, and they demonstrated better clinical efficacy with higher ORR and OS compared to chemotherapy. It was approved, dabrafenib as a monotherapy was approved by FDA in 2013 based on the higher ORR and OS data after progression on CT in the second line. However, majority of the patient developed progression after 6 to 7 months due to resistance. Higher incidence of hyperproliferative cutaneous event like squamous cell carcinoma and keratoacanthoma, which are mainly due to paradoxical activation of MAPK pathway, which we'll be talking in the next slide. Next slide, please. So this is what happens when you give monotherapy with the dabrafenib. There is activation of a parallel MAPK pathway that causes the resistance of resistance to this BRAF inhibition. Also, it causes the side effect, that is the cutaneous eruption. But when we combine it with another MEK inhibitor like tramitinib, then there is maximal inhibition of MAPK pathway, and it in combination improves ORR, PFS, OS, and preserve quality of life as compared to dabrafenib monotherapy. Addition of tramitinib, it also reduces the paradoxical activation of MAPK. Hence, the cutaneous event like squamous cell carcinoma and keratoacanthoma are also reduced. Next slide, please. So this is the pathway that we were talking. So after the transmembrane receptor binding, so there's receptor tyrosine kinase. So it activates the BRAF mutation, which is downstream, activates the MEK and ERK, but also there is paradoxical activation of MAPK pathway, so which is why the cutaneous incidences happen. Next slide, please. So this is how the resistance to combination therapy happens. So one is the ERK dependent and where is ERK independent. Next slide, please. So next I'll be talking about a few clinical trials on BRAF MEK inhibitors. So if that's like BRF 113928 study. So it was a phase 2 study in which 3 cohorts were taken. Cohort A had dabrafenib 150 mg twice a day monotherapy arm. Cohort B was dabrafenib and tramatinib combination arm. Both of them were given in the second line in patients who have already received platinum-based chemotherapy, while cohort C had combination only, but it was given in the first line in chemotherapy naive patient. So these arms cohorts had the number of patients 84, 57, and 36 respectively. Primary endpoint for each cohort were ORR and secondary endpoints for PFS, OS, and the safety analysis. Next slide, please. If we look at the cohort A, that was in the only the first 20 patient. If we look, the ORR was actually 40% when none achieving CR. 40% of the patient achieved PR. And more than 12 weeks stable disease was seen in 20% of the patient. 30% of the patient had PD, and disease control rate, which is cumulation of CR, PR, and stable disease, which is 60%, which is decent. Next slide, please. So it was the first study which demonstrated the clinical activity of dabrafenib monotherapy in BRAF V600E mutation positive NSCLC. It demonstrated an ORR of 40% and DCR of 60%. Partial responses were durable, and 2 patients continued treatment for more than 1 year. Safety profile of dabrafenib was consistent with the previous studies in melanoma, which is basically cardiotoxicity and diarrhea. Dabrafenib demonstrated promising clinical activity for patients with metastatic BRAF V600E mutation positive NSCLC. The study expanded sample size and now allows the enrollment of patients for the first-line therapy with dabrafenib. Next slide, please. If we look at the waterfall plot in cohort B and cohort C, if we look at the cohort B, so waterfall plot looks impressive with ORR of 63.2% and median PFS of 9.7%. However, if you look at the treatment naive patient respective to say the ORR was almost similar, it is also 64%, median PFS of 10.9 months. So having a median PFS of 10.9 months in second line before the advent of immunotherapy and all that happened. So it is really impressive. Next slide, please. If we talk about cohort B perspective, already discussed the ORR of 63%, median PFS of 10.2 months, and overall survival was 18.2 months. Next slide, please. Cohort C, we see that if we look at the independent reviewer committee assessed result, if we see, so ORR was actually 64% and disease control rate was 72%, median duration of response of 15.2 months, median PFS of 14.6 months. So combining these data, we can see in cohort B and cohort C both. So combination therapy was actually effective in both in the first line as well as in the second line. Next slide, please. So based on these results, FDA approved dabrafenib with tramatinib combination in BRAF V600E mutated NSCLC in 2017. In 2013, the approval was dabrafenib monotherapy, while in 2017, the approval came along with in combination with tramatinib. Next slide, please. Study combination of dabrafenib and binimetinib. It was a phase 2 open label study in which patients with stage 4 NSCLC who have BRAF V600 mutant NSCLC patient were taken. So this is how it was screened. You can see the waterfall plot on the right. So patient with treatment naive and previously treated, both kind of patient were taken, and encorafenib plus binimetinib showed a meaningful clinical benefit with a good clinical profile. If you see waterfall plot both the sides, so it was decent. Next slide, please. In the second line therapy, the high PD-L1 expression was seen in patients who are progressed on BRAF inhibitor. So immunotherapy drugs showed clinical benefits. So BRAF is actually one of the few driver mutations where immunotherapy has not been shown to be resistant, and immunotherapy works really well in those patients. In fact, they have higher PD-L1 expression. So the correct sequencing is going to be first line BRAF inhibitor followed by immunotherapy plus chemotherapy. Next slide, please. Coming to the adverse event, combination, if we see that the combination nausea, vomiting, diarrhea, that is a common, and fatigue. But if we look at the BRAF inhibitor like dabrafenib, arthralgia and QTC prolongation, and the cutaneous squamous cell carcinoma and acanthoma, although the risk is much lower when it is given in the combination. If we look at the MEK inhibitor exclusively, then cardiomyopathy and ocular toxicity are seen. Next slide. So because in clinical practice, we are mostly giving dabrafenib and tramatinib combinations. So we see Pyrexia and hyperglycemia, these are the two unique toxicity profile that is commonly seen. Pyrexia specifically is very, very troublesome in these patients. Apart from that, vemurafenib, cobimetinib, photosensitivity and skin reaction is also common events. Next slide, please. So if a patient develops pyrexia of temperature more than 38 degree and pyrexia syndrome, then we have to stop dabrafenib and trametinib combination. We have to rule out any kind of infections. If there are any infections, we need to treat that with appropriate antibiotic. When patient becomes symptom-free for more than 24 hours, we can reduce the dose of dabrafenib and trametinib and restart it. Next slide. To conclude, BRAF V600E mutation is less common in NSCLC compared to other tumors like anaplastic thyroid carcinoma, melanoma, and hairy cell leukemia. Routine testing of BRAF mutation should be considered in all cases of NSCLC, and we usually do it specifically. Now we have the combination panels available, and BRAF is a member of these. Even the minimal 12 gene NGS panel that we send, BRAF mutation is a part of that. Dabrafenib and trametinib combination oral therapies are considered to be more effective in BRAF V600E MNSCLC regardless of prior therapy. So it can be given in the first line as well as in the second line. And BRAF inhibitors in non-V600E mutation, which is sometimes seen, it is not known, although we can, as a matter of trial, we can give benefit of doubt and we can give dabrafenib and trametinib in this population as well. Another most important point is BRAF is the only driver mutation where the effect of immunotherapy is still there, and in these kind of patients, immunotherapy and chemotherapy combination can be tried in the second line onwards, and the effect of immunotherapy will be there. Thank you so much. So next slide, please. I think that is the last slide. Yeah, over to the organizer.
Okay. Thank you, Dr. Kapil Goyal, for such a crisp yet elaborate talk. It was really helpful for all of us. Thank you once again.
Thanks a lot, sir.
And so we are done for the day. And once again, I would like to thank all the speakers, delegates, sponsors, and the entire technical team. So call for day and see you tomorrow at the 7 o'clock sharp for the day 2 discussion, and where we'll be discussing breast cancer in and out. Thank you all.
Thank you, sir. Thank you everyone for joining, and we'll meet tomorrow at the same time. Till then, good night. Good night, everyone.
Good night, everyone.
Thanks to my academic partner, and thanks to my team, Nishant and Rishabh, and thanks the technical support.